I hope you are all good.
Good morning.
Yeah, good.
Okay.
Yes, sir, we are fine.
Okay. Good to see you all again. Before we close this session this morning, we'll try and take a picture. So we'll ask everybody to put their camera on, and then we can take a picture. We should have done this on Monday, but I think he skipped us. I hope everybody is okay with that.
Except for some of us that are not photogenic.
That's fine.
Yeah.
We need a group picture to promote the course on our social media handles. So if you are photogenic, that's fine. We can just take a blank page of you. So that's fine. Yeah. It's not a prescription. So if you have for it, when we call for it, you can just put on your camera and then we can have a nice shot. Okay, thank you very much. I hope you had an interesting session on Monday.
Yes, sir.
Okay, great. So we're going to build on that. I'm going to introduce you. I'm sure there are many on the call that already know what the discipline of epidemiology stands for. Maybe there might be others too. It's your first time. So what I'm going to do is that I'm going to expose you to the discipline, some scope, objectives, relevance, and then try and look at how, we can leverage the discipline to enhance data science work or whatever it is, whether we can also leverage data science to improve epidemiological work, whatever it is. I'm sure that will be the discussion aspect of what I'll do today. And indeed, that will serve as your assignment. One of the requirements of the course is to give you an assignment for you to submit. I spoke to Agnes. Agnes is preparing an assignment which you receive by the end of the week. Yeah, so it doesn't take away anything if I introduce myself again. On Monday, I did. I'm the course leader together with one lady in India called Tinku Thomas. So we are leading this course. This course is generously supported by the Gates Foundation that has enabled us to put this package together. The package is for this course. So we are hoping that, as I indicated on Monday, you guys will serve as the ambassadors so that we'll be able to leverage on this first delivery to get some substantial funds, probably even do it as an in-person course rather than a virtual course, which comes with several challenges for both the instructors and also for yourself. I am an associate professor at the University of Cape Coast here in Ghana, and I have a very small public health research group here, and our work is mainly in nutrition and environmental health, nutritional and environmental epidemiology. Okay, so what is epidemiology? Who wants to tell us? Those of you on the call and you know what epidemiology is about. Do you want to tell us, please, you want to tell us what epidemiology is?
Can I speak?
Hello?
The epidemiology basically study upon population related to
The
disease.
studies. Okay, sure. Anybody has another definition?
Hello?
Anybody has another definition or something to add?
Hello?
Yeah, we can hear you. Please talk.
Okay, so epidemiology essentially means like the study of diseases or health events with regards to, with special emphasis on the factors which are either predisposing factors or deterrent factors. So essentially it's about the who, where, and essentially like why of diseases and other health events.
That's great. I like that very encompassing definition you've given. You've talked about the distribution. You've also talked about the determinant. So let's see what I have here. Are you able to see my slide as I change them?
Yes, Prof.
Yes, sir.
Okay.
Yes,
sure.
you can see.
Okay, that's great. Okay, so now I want to go into, So epidemiology, as he indicated, is the study of the distribution. So we are interested in the distribution of disease. We are also interested in the determinants. But traditionally, we have focused on diseases because the discipline evolved out of those who were doing infectious diseases. If you look at the founding father of the discipline, which is John Snow, I don't want to bore you with history, but what he did was try to understand cholera events in the Lambeth area in London. So the discipline evolved out of, those were the people that carved the discipline out. So you can understand why traditionally it has been the mainstay of those doing infectious diseases. But now it has extended. Now we are doing chronic diseases, we are doing genomic epidemiology, we are doing molecular epidemiology, we are doing nutritional and environmental. So that's the reason why we have stretched the definition to be determinants of health-related state or events. And I want to emphasize that it should be in a specified population. So it could be the general population of the world, but that is very key. But you see, when we are doing this, so basically we are investigating diseases. We are trying to establish the causes of diseases. But when we do this, we need to also find a way to apply the knowledge that we have to control the health problems. So that is the public health aspect of the whole thing. Indeed, epidemiology and biostatistics are the foundations of public health. So when we get the information or the evidence that we want, we should be able to also use that to control health problems. So I break it down. So when we are talking about distribution of diseases, we are interested in who is the disease affecting. And I like the gentleman who gave me the second definition. He talks about the who, the why, and the where, and all those things. So we are interested in who is the disease impacting. We are also interested in the place, where is the disease occurring most, and then also the time. So when COVID was with us, you realize that we were interested, those that were giving us the figures all the time were telling us who the disease was impacting the most. They were talking about the elderly. They were talking about those who have underlying diseases like diabetes, like hypertension and stuff. We're also interested in the epicenter. It started in China. US was one of the epicenter, Italy, and all those things. And then also the time period. So these are the very three closely interrelated components, and this encompasses all epi methods and principles. So if you are involved in any epidemiological study, and we want to interrogate what you are publishing or what you seek to publish, we want to know your study population. We want to know where you conducted the survey to understand whether indeed the evidence that is emanating from that population will be of relevance to the entire scientific community and also to be used to address health problems globally. We are also interested in the time that you are conducting the study. So simply, those of you who have had the opportunity to look at systematic review and meta-analysis, the classic table 1, which summarizes the information for the studies that you are synthesizing, has this study population, the location, and then the time period. So when we are talking about the determinant we are interested in geophysical, turn and push hard. Geophysical, we are also interested in the biological, we are also interested in the behavioral factors, we are also interested in the social factors, the cultural factors, economic, as well as political factors that influences health. And the list is exhaustive. So in simple terms, epidemiology is the study of how diseases are distributed in populations and the factors that influences the distribution. And the factors is what we always try to understand. For example, when COVID was asked, we were trying to look out for the driving factors. Once you know the factors, then you can put in an intervention to mitigate, those factors, or you can put in an intervention to control the diseases. So there are some fundamental assumptions of epidemiology which I want us to all appreciate, before we continue. And the first one I want you to understand is that we don't get diseases as a result of chance. Diseases does not occur as random. It's not randomly distributed in a human population. So so the first statement I said holds true. So you are not getting diabetes, or you are not getting hypertension, or you are not being afflicted by COVID-19 or malaria because of chance. It doesn't happen like that. It's because of some predisposing factors. You found yourself in some population, you found yourself in some location, you are indulging in some bad lifestyle practices or poor nutritional practices, or by virtue of some work you are doing, you are exposed to some occupational exposures or environmental exposure. That is the reason why you are getting the disease. So it's not a matter of chance. That's not how disease happens, you know. So rather, each person has a certain characteristics, and it could be your genetic constitution. And that is the main reason why now genomics has a very huge influence on epidemiological work that we are doing. And I have a slide on that. So rather, each person has a certain characteristics that predisposes to or protect against a variety of disease. So maybe by your genetic constitution, it predisposes you to a disease, but somebody, because they don't have, I'm not a geneticist, but they don't have, whether I don't know the allele or whatever it is, it protects them against the disease. Also, human diseases has causal and preventive factors. So every disease has a cause. And as a result of that, we can prevent that disease. So hypertension and those things, diabetes that we cannot treat, we are just managing them. They have causal factors. And because they have causal factors, if we are able to systematically identify these causal factors, we can definitely prevent those diseases. And that is the reason why there are interventions, nutritional interventions, there are social interventions, there are built environment interventions, if that is what I want to put it. That is all targeted towards controlling human diseases. Then often we are dealing with an interaction of genetics and environmental factors in the development of disease. So the environmental factors here is stretched. You have nutrition in there, you have social factors in there, and you have an interaction of these factors with your genes. And that is what leads to the development of disease. So that is the reason why somebody might ask, I have a colleague who has smoked for 50 years, he never gets lung cancer. But then have another colleague, he started smoking 2 years down the line or 3 years down the line, he has lung cancer. So often this has got to do with your genetic constitution. So this is a slide that I usually use in my lectures, and I attended a conference and it was presented and I stole it and I have been using it. So it says genetics loads the gun, but the environment pulls the trigger. So your genetic constitution predisposes you to a certain disease. So we are all at risk. In epidemiology, we usually say we are all have the baseline risk. What we are interested in is the excess risk. We are all at risk of lung cancer. We are all at risk of malaria. We are all at risk of any disease out there by virtue of our genetic constitution. So that genetic constitution has loaded the gun. So therefore, if you are indulging in some bad practices, poor nutrition, environmental exposures, blah, 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 then that is what is going to pull the trigger. So that is what this slide talks about. Any question at this stage? I want the lecture to be very interactive. So if you have any questions at this stage, please chip in. If you have any addendums, it's also allowed. Any questions? Okay, so your silence means I can continue. So what is the aim of epidemiology? What is the aim of epidemiology? The aim of epidemiology is to promote, protect, and restore health, and also advance scientific knowledge. So we are not only interested in promoting, protecting, and restoring health, which is the mainstay of public health. And that is what you see in the next pointer. Now, basically, it helps us to achieve the public health goals. Those of you who knows the definition of public health, the act and science of blah, 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 managing, protecting. So that is what epidemiology seeks to do. As I indicated earlier on, is epidemiology and biostatistics are the foundations of public health. Those are the two disciplines on which public health thrives, you know. But we are also interested in advancing scientific knowledge, you know. But the key question I have for you here is that how can the discipline help to achieve the goals of data science? So here I want to hear your voice. And that is your assignment in any case. How does the discipline help to achieve the goals of data science? So this course, what we seek to do with this course is to build a critical mass of public health data scientists, as I said on Monday, in the developing regions of the world, you know. And on Monday, we had Agnes introducing you to what data science is, which is basically about large data and how we want to use that to make decisions. So those are the things that I have there. So the goal of data science, I'm sure you got it from Agnes, is to help people make better decisions. Data science is about predictions, it's about forecasting, it's about having large and complex data which we can glean insight from. So if you have a discipline of public health, and I've already set the boundaries, how can we leverage the discipline to achieve the goal? Somebody want to come in quickly?
Okay. Can I come in, Prof?
Yes, please. Yes, please.
So I think from what I picked from our last lecture, applications of AI, and what I'm picking from issues to do with epidemiology, by establishing the factors that actually predispose a person to diseases, we can then be able to use AI in order to track those circumstances, conditions, and develop mitigatory measures or probably preventive measures through developing algorithms that can actually then be used for that purpose.
Great, great. I think that's exactly the answer I was looking for. But yes, we are open to another angle of the discussion. So if anybody, I can take another one or two and then I can summarize the points and then we can move on. Anybody has a different view or something to add or subtract?
Yes, if I may come in. So
Sure,
epidemiology, yes. It's a data-driven field as well, and it relies on systematic approach to the collection, analysis, and interpretation of data. Yes.
And so on the basis of that, what are the synergies? Based on what are the synergies between that and data science? Or how does that help to drive one discipline or enhance one discipline? Hello, Easter, are you there? Okay, so let's carry on in the interest of time. We are way behind time. So basically, from the very first answer, yes, epidemiology is also a data-driven, and now there's big data. Big data has taken over epidemiology, you know, and that is the more reason why people are moving gradually, shifting into data science. And in fact, one of the things that we have also started doing in our group here is to leverage data science techniques for some investigations. But I think what he identified was that the epi discipline, because it tries to uncover the risk factors, it helps us to get the candidate predictors. So I think that is a term in AI. I'm not an AI person. What they do is that they do model training. I'm sure you want to train your model. So you collect a number of data, very huge, and then they said there's something they call you train some model. Basically, what you are trying to do is to develop some prediction equations. So for example, typically you could decide that we want to develop a model to detect for early detection of hypertensive disorders of pregnancy, so that mothers that are at risk of hypertensive disorders of pregnancy, we can quickly identify them and then put in an intervention so that we can prevent fatal outcomes. So what this discipline can do here is to help us to identify the candidate predictors so that we can assemble data on those candidate predictors for the model training. I have a number of objectives. So these are the objectives of the discipline. We can just go through. If there's anything I need to explain, then I'll do that quickly. So 1, identify the etiology or cause of disease and the relevant risk factors. 2, determine the extent of disease found in a community. So these are burden of disease in the community. And that's what has been happening around us for the past 10, 15, 20 years, where you have the institute in Washington on a yearly basis trying to generate the burden of disease estimates globally for us, and which they publish in the medical journal Lancet all the time. 2, study the natural history and prognosis of disease. 4, evaluate both existing and newly developed preventive and therapeutic measures and the mode of healthcare delivery. So we do this with intervention studies, the trials. Provide a foundation for developing public policy relating to environmental problems, genetic issues, and other considerations that regard disease prevention and health promotion. So here, the findings, the evidence that we churn out from our research endeavor is used to develop policy. It informs policy, and these policies help to address some of these challenges that impact health. Then a major role of epidemiology is to provide some idea of the changes that occurs over time in a community health problem. So for example, we are interested in what's the pattern of diseases seen in developed countries. What is the pattern of diseases seen in developing countries? What is the burden of disease globally or locally? What are the leading causes of death? And this is where the global burden of diseases studies come in. What are the main activities or the fundamental activities of the discipline? So, primary discovery of the causal agent of epidemics, determining the magnitude and determinants of morbidity, mortality, and health in defined communities, identifying high-risk populations, and this is very critical. It's important that we know those who are most the susceptible populations so that we can put in an intervention. And then also an independent evaluator of health programs. So those of you who are biochemists, molecular biology, what is genomics? Can you educate us? There are people on the call who are, this is your staple. What is genomics? Who can tell us what genomics is? Do we have any geneticists on the call, any molecular biologist? I think we admitted a few.
But I think genomics is the study of genes to identify diseases that predisposes people to, or rather risk factors that predisposes people to diseases.
Okay. Any other contribution? Any other contribution, please?
Yeah, here. Can I hear me?
Yes, sir. I can hear you.
Yeah, genomics is actually related to the study of genes that are, for example, how the gene encode the proteins and all the factors they are related to. The factor related to the diseases that can be caused from the gene. So actually, genes are responsible for multiple type of protein. So some protein are helpful and some protein are very dangerous. So this is the overall study of the genes.
Yeah. So I think that's exactly what it is about. It's more about your gene series. So your gene series, that's what genomics is all about. But there's been a rapid development of this in the 90s. And because of that, you realize now a lot of people are doing gene environment interactions and all those stuff. And this has had a very profound effect on the third activity, which I said is very critical, trying to identify high-risk populations. So because of this boom, if that is the word I want to use, boom in genomics, over the past 3 decades, 2 or 3 decades, it's had a very profound effect on the third activity. And what is this effect? It means the discipline now is shifting. So now you realize that the discipline of epidemiology, people are no longer doing this cross-sectional and more association studies. But we have moved from identifying the high-risk population on the basis of demography. So first, the concentration was how was age related to this disease? How was race related to this disease? How was sex? How was your socioeconomic status? But now we are attempting to define individuals within the population on the basis of genomics. So if you want to tie this to my earlier submission about genetics loading the gun and then environment pulling the trigger. So now we are interested in your gene sequence. And then once we know your gene sequence, then we should be able to know which of, like I said, I'm not, so forgive my ignorance, which of the alleles or whatever you possess that predisposes you to this disease on the basis of you having this age or you being of this race or you being exposed to this environmental exposure. And this enables us to do something we call precision medicine. So this enables us to do something we call precision medicine. So once we know your gene sequence, then the intervention, the medical intervention can be targeted towards your gene sequence. And this is a very nice article on that, which I encourage you to read. So what is the relevance of the discipline? So what is the importance of epidemiology, especially to public health practice? So it helps us to identify the subgroups in the population who are at high risk of disease. But the key question here is that why should we identify high risk people in the population? When we do this, we are able to develop direct preventive efforts. It also enables us to modify the risk factors. You know, we have 2 sets of risk factors. We have the modifiable risk factors. We have the non-modifiable risk factors. The non-modifiable, you can't do anything about it. We can't change your race. If your race is predisposing you to this disease, we can't change that. If your age is predisposing you to these diseases, we can't change that. But if your location is predisposing you to a certain disease, you can change your location. If smoking is predisposing you to lung cancer, of course, you can stop smoking. So that is the more reason why we need to know the high risk groups. And once we know that, then it enables us to put in an intervention. So there are 2 main approaches to disease prevention. We have the population-based approach, and then we also have the high risk approach. So the population-based is interventions that targets everybody in the population-based. Whereas the high risk approach is more like those of you who know your EPI stuff, that is stratification analysis or effect modification. So we do a stratification analysis to see whether a variable is an effect modifier. Then enables us to know the groups that are the subgroups that are most at risk of the disease. So you realize the effect estimate is higher in those groups. Then we can put in intervention. So for example, we stratify by, let's say, sex. We realize that males are at higher odds or higher risk of the disease. Then whatever intervention we have to target it to males or boys, and that is the high risk approach. But I want you to also keep in mind that epidemiology is important not only to public health, but also to clinical practice. Because the practice of medicine also is also dependent on population data. And that is more clinical epidemiology. This systematic reviews, meta-analysis that we do where we try to summarize the body of evidence. It's all to inform clinical practice. These clinical trials that are being conducted to evaluate the efficacy or effectiveness of a therapy or whatever, or an intervention is all geared towards enhancing clinical practice. So what is the approach What is the approach? How does an epidemiologist proceed to identify the cause of disease? So somebody want to tell me, how would an epidemiologist proceed to identify the causes of disease? Let's say we are interested in the driving factors of COVID-19. How do we proceed?
Sorry, can I try?
Yes, please, go ahead.
Okay, so probably you actually look at the exposures of a particular group of individuals who are actually affected by that particular disease. So you can actually do maybe a case control study, like you look at those individuals who do not have that particular disease, and you look at those who actually have the disease. Then you go back to actually look at the differences in exposure between the two groups to actually establish maybe the causal factors for that particular disease.
Yeah, that's great. So what in essence is saying is that we need to design a study. And then I like how he brings in a design that we can use a case control study. So you have your cases, those who have the disease, those who do not have the disease. So you sample some cases, you sample some controls. And what he talks about here is that we need to try and establish their exposure history and then compare. Once we compare, and I like the word comparison. So one of the things about epidemiology, especially analytical epidemiology, is that you always need to have a suitable comparison group, something we call the counterfactual. You know, once we compare, then we'll be able to know whether indeed this factor is associated. I want to use the word association now. I don't want to use the language of causality. This factor is associated. You know, from association, we move from association to causality. So that's the approach. So just to run through, determine whether an association exists between an exposure to a factor, and those exposures are what you see there: nutritional exposures, environmental, social, or some characteristics, your genetic constitution, your blood pressure or whatever, and then development of disease. Then, if we find the association between the exposure and the disease, so as the gentleman highlighted, if we find an association between exposure and disease with case control design, then we can proceed to determine whether that association is causal. But I must caution here that there are some of the designs you cannot use to establish causality, because the problem is that you can't establish temporality with those designs, like the traditional case control study, as he described, like the cross-sectional study. We are not able to know whether indeed exposure preceded the outcome. So it does not enable us to establish causality with those designs. But the rigorous ones, like prospective cohort studies, can allow us to do that. But you always have to be careful in your write-up when you are introducing causal terms and causal language. But any study that you are doing, it often begins with describing the data, and this is the mainstay of descriptive epidemiology. So disease transmission, maybe I just want to brush this off. I think that is even about my last slide or something. So disease transmission, this is more infectious disease, why we can just quickly brush, because I want to introduce that epidemiologic triad. So human diseases arise as a result of interaction between the host factors, that is the person, an agent, and also the environment. And that is the epi triad, which you see up there. So you have your host, you have your agent, you have the environment. Although some diseases are largely genetic in origin, almost all diseases result from an interaction between genetic and environmental. So this is just to emphasize the point or reiterate what I said earlier. Your susceptibility to disease is determined by a variety of factors. So again, genetics, your nutritional practices, and also your immunological, whatever it is. So these are some of the factors that can influence diseases. So you have the host characteristics. Most of them are non-modifiable. You know, you have age, race, but what I want to emphasize with this is that usually in the relationship that my friend described, you have to also control for some potential confounders. And those host characteristics usually serves as the covariate in your models. Then you have the agent factors, and then you have the environmental factors, which are more often than not the exposures. Then your single exposure, what is epidemic? Distinguish between the three. I'm sure everybody is familiar with endemic, epidemic, and then yes, the amount of disease in the population depends on a balance between the number of people in that population who are susceptible and are therefore at risk of the disease, and the number of people who are not susceptible or immune and therefore are not at risk. So there has to be a balance. The disease, the amount of disease is a balance between those in the population who are at risk and those in the population who are not at risk, based on the fact that they have some immune, they are immune from the disease, or they have been vaccinated or whatever. So they may be immune because they have had the disease previously, or because they have been immunized against the disease. They may also be susceptible based on their genetic constitution. I guess this is my last slide on the introduction. So if we want to explore disease occurrence, we are interested in who, when, and where. Again, just to reiterate the point. So characteristics of the host factors of the human host, sex, age, race, etc. Certain disease occurs with a certain periodicity. And then disease is not randomly distributed in time and place. And I have said this already. So any questions before I go to study designs? Any questions on what I have discussed so far? Any burning questions? Yes, sir. Go ahead.
You actually mentioned something about the public health and the clinical practices. So what is the difference between the two?
Public health and clinical practices.
Right, exactly.
Yeah, I was expecting, what's your background?
I'm a microbiologist.
You're a microbiologist. Okay.
Yes.
Who is a public health physician on the call, or who is a clinician on the call to help him answer that questions? Who wants to help?
Can you repeat the question?
Yeah, he said he wants to understand the difference between clinical practice and public health practice. That's what you said. That is what you want to know, isn't it?
Yes, exactly.
Yeah. And I want those who are public health physicians or clinicians or public health practitioners to help us answer your question.
So can I answer that question?
Yes, please, go ahead.
So basically, I'm an Ayurvedic doctor now practicing in public health and community medicine. So when we talk about curative aspects or the medical practice or the clinical practice, we are pointing out the individuals, those who come with diseases or any health issues. But when we talk about the public health issue, we are taking any health issues, it can be related to physical, mental, social, any health issues in a public domain, that is a population level or the community level. We are not focusing on an individual, but in a community.
Yeah, great. That is a very great answer. So basically, from the science aspect, clinicians are interested in the biomedical view of health. So they are interested in treating diseases. So as she said nicely, people come with diseases and then you treat them and then they go away. You are not really interested in what is causing the disease. You present with malaria or COVID-19, we give you a medication and then it solves your problem, you go away. We are not interested in what is causing the COVID-19. But for a public health physician or public health practitioner, they are into the holistic view of health. So they are interested in what is impacting or driving the diseases around. And that is what she said, we are interested in the health of the population. If somebody presents with one disease from a community, we are interested in whether this is actually a problem in the community that the person is coming from, so that we can go in there and put in an intervention. Please, I hope both of us have been able to answer your question.
Thank you very much. It was a nice explanation.
Okay, thank you very much.
quite a good explanation.
Okay, thank you. Anybody has any other question? Okay, so let's boss on. We have to try and finish around 10:30 or whatever it is. So let me stop sharing this. So study designs. Towards the later parts of the first session, we tried to find out what was the approach. How do we investigate the relationship, or how do we investigate the causes of disease? And my good friend on the call explained nicely what a case control is. So one of the basic things that you need to appreciate, or you need to try and be equipped with, is study designs. You need to try and understand the study designs. There are a number of study designs. We have observational designs and interventions. You need to appreciate and understand what they are, because those are the designs that if you have a burning hypothesis, if you have something on your mind that you want to investigate, then you have to identify or select one of these designs and then use that to answer the research questions that you have. So I'm going to quickly take you through study designs in the next 45 minutes or so, or maximum 1 hour, and then we can close the first session. And then I feel rather than a 30 minutes break, I'll prefer we take an hour break, and then we can come back and do another 2 hours, and then we should be done for a day. It's a big thing we have compressed in about 4, 5, 6 hours that we are doing on this program. So let me start by trying to identify what variables that we try to measure in epi studies. Some of them I've just talked about them. So for any epidemiological study, you are collecting data on 3 variables. You are collecting information on 3 variables. Your primary exposure of interest, and then other exposures that may influence the outcome. So these are the potential confounders. And then the outcomes. I'm sure many on the call know what the confounder is. But simply, if you are interested in the relationship between X and Y, there could be a third variable that is linked to S and also associated with Y. And once you don't adjust for this third variable, then whatever you are seeing becomes a spurious finding. So it's always important that in your multivariable analysis, you adjust for this third variable, and then we can see the clear relationship between X and Y. So you are also interested in collecting information on these variables, this third variable, which is the confounder. And then also you are collecting information on the outcomes. The difficulty here is that for the exposures, you have set up your study. So you know what exposures you are interested in. You are interested in smoking and lung cancer. So of course, you are going to go out there and try to find out who is smoking, who is not smoking, and then the amount of cigarettes they are smoking in a day or in a month. You are interested in lung cancer. So if it's a cohort study and you are following them, who gets the disease, who does not get the disease among exposed, unexposed group. Or if it's a case control study, you are selecting lung cancer cases and the suitable controls from the hospital or the community. But the difficulty is, how do you identify the potential confounders? Who can answer that so that we can collect information on that? How do you identify the potential confounders? So you want to investigate lung cancer and then smoking and lung cancer. How do we overcome the challenge of identify what should be the potential confounders of the relationship so that we can collect data on that? Quickly.
You usually go to the literature to see what has been found before as confounders. And then you put study.
Thank you. So you have to peruse the literature. So the literature is saturated with a lot of these information. So as you read and read, you start to know which of the factors are associated with the exposures, smoking, what factors are associated with the outcome. And then on the basis of that, you can collect data on those potential confounders. The exposure of interest may be associated with either an increased or decreased occurrence of the disease. So you might, when you establish your association, you might realize that, oh, indeed, smoking is not even a risk factor for lung cancer, but it might have been or is protective. So that is what we mean by increase or decrease occurrence of disease. Then outcome of a study is a broad term for any disease state. Any disease state of health, health-related event, or so your outcome could be death, could be whether someone dies or survives, especially in survival analysis. It could be lung cancer. Your outcome could even be an exposure, with the outcome rather being your exposure, depending on what sort of study that you want to set up. And these are the types of exposures that we have around us. But the list is endless. You have your genetics, you have your demographics, you have your diet, nutrition, physical activity, you have lifestyle practices, smoking and alcohol intake, you have medication use, you have environmental factors, air pollution, water and sanitation, you have occupational exposures, pesticide use, mining, and then you also have the infectious agent. And now you even have green spaces. We have stretched it. Now green spaces. There's a lot of literature that is coming out on green spaces and health. You have your built environment. They are all a range of exposures that you can assess. And you need to clearly define these exposures and outcomes at the start of the study. And as I indicated, the exposure of interest in one study may be the outcome in another study. Typical example is we could be interested in how maternal disorders of pregnancy influences birth outcomes. So maternal disorders of pregnancy, which could have been a traditional outcome in a traditional epidemiologic study, now becomes an exposure, and then how that is influencing birth outcomes. Another example is how birth outcomes influences growth trajectory of children. So whether a child is born low birth weight or normal birth weight, whether a child is born preterm birth or term birth, how that informs the growth trajectory of those children, whether they become stunted, they become wasted, or they become underweight. So this is what I used to summarize my EP designs. So at the very top, you have a second. So at the very top, you have the investigator assign the exposures. Did the investigator assign the exposures? So this is the first question you need to ask yourself. The exposure that you are dealing with, are you assigning the exposures or not? If you are assigning the exposures, that is, you are determining, you go to this group and you are the exposed group. You go to this group, you are the unexposed group. Then that becomes an experimental study or intervention study. But if you are not assigning the exposures, then that is an observational study. So let's stay on the experimental study. With the experimental study, is it random allocation? Are you randomly assigning the exposures? If you are randomly assigning the exposures, then it becomes a randomized control trial. But if you are not randomly assigning the exposures, then that is a non-randomized control trial. I hope that is very clear. Is it very clear, please?
Yes, sir.
Yes,
It's very
Prof.
clear.
Okay, thank you very much. I appreciate that. Then If it's an observational study, what is the comparison group? Do you have a comparison group? If you have a comparison group, that is an analytic study. Please, 1 second. If you don't have a comparison group, then that is a descriptive study. Please forgive me 1 second. I need to respond to some message. So, observational study. Do you have a suitable comparison group? Yes, then that becomes an analytic study. If you don't have a comparison group, then that becomes descriptive study, descriptive epidemiology. And if it's an analytical study, what is the direction? What is the direction? Are we moving from exposure to outcome? Are we moving from outcome to exposure? Or are we assessing exposures at the same point in time? So if we are moving from exposure to outcome, that is, we are assembling people according to exposures and then follow them over time, over a number of years to see who gets the disease, who do not get the disease in both groups, then that is a classic cohort study, what we call the prospective cohort study. But then if we are picking outcomes, who has the disease, who do not have the disease, and then we assess their exposure history, then that is the traditional case control study. And if we are assessing exposures and outcomes, including the covariate at the same point in time, then that is what we have as the cross-sectional study. So this is the schema that can help you to distinguish between the various types of study designs that we have in epidemiology. The rest is all about text. It's all about what are the limitations, what are the shortcomings, what are the strengths of those designs.
Question?
Sure.
So where would you put a retrospective cohort study?
So where would we put a retrospective cohort study? So the difference between, so I'll put a retrospective cohort study, I'll align it with the cohort study. But the difference between the retrospective and then the prospective is just the calendar time. If you know, I'm sure you know that. It's just the calendar time. So with retrospective back in time, we are assessing medical records, you know, whereas with the prospective, we are assembling them and then following them. So we'll still put them in this block. You see other schemas. You see other schemas that have an endless list. In fact, I have another schema, but I had to distill these notes for this short course. So I had to remove those ones where you see a number of things. You realize I've not even put case series and case reports there. I've not put ecological studies there. Those are all epidemiological designs. But the interest here is on those that are more robust or somehow robust that we can use to elucidate our relationship. Are you okay?
Yes, thank you.
Okay.
Yes,
sure.
yes, thank you.
Okay, so this is classic cohort study. So in a cohort study, what we do is that in a defined population, you assemble people according to their exposure status. So who is smoking, who is not smoking, and then you follow them over a period of time. And over that period of time, who gets the lung cancer, who does not get the lung cancer among the exposed group. Among the non-exposed group, who develops lung cancer, who doesn't develop the lung cancer. And then because this is a longitudinal study or a cohort study, here we are getting incident cases. It's not prevalent cases. We are getting incident cases. So we can compute incidence of disease among the exposed group. We can also compute incidence of disease among the non-exposed group and then compare, as my friend said, we compare those incidents, the two incident rates Then once we compare, then we have a relative risk, a risk ratio or a rate ratio. We can compare, and then that enables us to determine whether there's a relationship between smoking and lung cancer. So here we have what I've described is the typical prospective cohort study. Then we also have the retrospective, which ISTA wanted to find where we can situate that on the schema that I provided. So with the retrospective, the cohort is identified and assembled in the past on the basis of existing records. And then it's very tricky. Sometimes it's very difficult to understand what we are trying to put across. So you can go to a factory and then you try to identify a cohort and then you assemble them based on the past history or the the records that exist in that factory. And then you are following them over 20 years or 10 years. So you are assembling the cohort from existing records for 20 years. And then you try to catalog the series of events that have happened during that period of 20 years. And then usually, if that factory has a clinic, you can also get the medical records from there so that you can get the outcome information. Or if it doesn't, then you have to find a way where you can get the medical records of those people that are working in that factory from a clinic or a hospital in that location. And then you can link both information up. So the difference between the two is the calendar time. Whereas the cohort, we are moving from A to B, the prospective with the retrospective, we are moving from B to A. The main limitation of prospective cohort studies is attrition. Because of the long duration of follow-up, usually you are following people up for 5, 10, 20 years. And you're going to have people moving out of the location. And once you are moving out of the location and you are no longer in contact with them, then they've been lost to follow-up, what we call losses to follow-up. And that is the main limitation of cohort study. So usually to guard against this, you need to have something we call very strong participant retention strategies. You have very strong participant retention strategies, and that will enable you to hold the cohort. Those who have been through an EPI course, can you identify 1 or 2 participant retention strategies for us so that we can have a very high response rate in our cohort studies? Maybe Easter, you want to help us? Sorry for picking on you. Anybody wants to identify 1 or 2 participant retention strategies for us? Yeah, Adam.
Yeah, thank you, Prof. So I think you can decide to pick more than the number that you are expected to, or the sample size that you expected. So, example, if you expected to sample 200 participants, you can decide in this case sample 220, so that at the end of the day, if there is any loss to follow up, it will still come back to the number that you are expected to recruit.
Yeah, I understand where you are coming from. Usually, sometimes some of these things are oversampling, because in your calculation, you have already arrived at that 200. That 200 has also taken into consideration the losses to follow up. So that 200, you cannot settle on that 200 and then go to the folder and say, I'm going to sample 220. That's oversampling. So what I'm interested in here is the 200 that you decided to sample for your study. How are we going to hold all that 200? Okay. Ahmed, your hand was up.
Okay.
Yes, please. Okay, when Ahmed, yeah, I like the way the flood of people that wants to answer that question. Yeah.
Yeah, so one strategy is to use active follow-up instead of passive follow-up. Yeah, so active follow-up means you go directly to go and get those participants to reach out to them instead of just allowing them and just telling them, okay, after 2 months, every 2 months, make sure you come for follow-up. So you now actively go and search for them when the due time has arrived. That's one strategy. Another is probably like using like reminders, like reminder phone calls. That could also be another strategy for maximizing retention. Yeah, thank you.
Okay. Yes, there were a flood of hands up. Please, I want to hear from everybody.
Okay, maybe you can also though it's not actually maybe one of the best strategies, but then you can actually introduce incentives for the participants.
Incentives, yes. Okay. Yes, Easter, your hand was up.
Yeah, I think what I wanted to say has been said, but my points were on contact tracing, active contact tracing, through SMSs, phone calls, and home visits.
Yeah,
yes.
Same, just same as the active follow-up. Yeah, but you have provided us with more details. Yes, I saw more hands. There were 2 more hands up. Great.
Hello.
Okay. Yes.
Hello,
Somebody
Prof.
wants to say something. Yes, go ahead, please.
Yes, first of all, I think there should be a clear communication, and then the researcher or the person involved should try and build trust, because the people need to trust you with their information and confidentiality, and there should be clear instructions, and then prompt reminders, which will be very convenient for the person to engage in the study. Then there should be another opportunity.
Okay.
There should be another opportunity to provide some support to the participants and some incentives or even recognition of these people. Then also participant engagement. So you have to foster a positive, engaging relationship with the participant throughout the study. Yeah, and then you should also be ready to get regular feedback so that you can share these aggregated findings and outcomes with participants whenever it's possible.
Okay, great. Great. Anybody wants to add anything, or we can boss on?
Also, participant retention can also be maximized by ensuring that proper consenting. So at the time you're giving the information, ensure that the information is correctly passed to the participant, because even misconception of when they're supposed to return for their follow-ups might also, or the importance of them completing all study visits might also reduce or increase the chances of losses to follow-up. So, but if participants get the importance of completing the all study visits, then it's likely that you would maximize their retention.
Okay. Any other person wants to add something?
Okay, maybe you can also.
Yeah, go ahead, please.
Okay, I was suggesting that maybe you can actually even choose convenient locations, let's say for in-person study visits. Instead of actually calling them to a particular location, you can actually try and find out which area is actually convenient for you to actually meet up with them.
Okay, sure. Yes. There was another hand up.
So I would like to add one point that if the researcher reached the participants, the follow-up will be more than the participants reaching the research.
Come again, please, Katrika. Please come again.
Sir, I would like to add one more point in order to, have more to retain the participants or to have high follow-up rates. So if the participants want to come to research, it will be difficult for them. Instead of that, if the investigator or the researcher goes to the participants, the follow-ups will be high.
Yeah, okay, great. So these are all good points. And in fact, this is the exact compendium that I wanted to put together as a strong participant retention strategy. But one thing that is missing, and let me highlight that, is that at the start of recruitment, is very important, it's critical to ask the participant, are you going to be in this location for the duration of the study? Nobody can predict, but at least for me, I know I'll be in Cape Coast here till I retire. I'll be in Cape Coast here till I retire, you know. So maybe that is a question you can put up to the participant, that how certain are you that you are going to be in this location, especially for studies that don't require a very long duration of follow-up. So typical example is if you are following pregnant women, a birth cohort, you are following pregnant women, the duration of follow-up is 9 months. So for 9 months, at least, the person should be able to tell you that I'm going to be in this location for 9 months. If the person tells you, my husband lives somewhere else, and I'm sure after 6 months or when I'm due for delivery, I'm going to move away to my mom's or my husband, then there's no point recruiting such a person into the study. Right from the outset, you know this is a case that will be lost. So you don't have to recruit such a person. So from the list that we built, from the answers that I got from you, that is one thing that was missing, and I'm sure you can all add it up to the information that you provided. Thank you very much. I appreciate that. Then we have something that we call in the advanced EPI textbooks, you will see another design they call ambidirectional. Sometimes I struggle to understand what this design stands for. And it incorporates both the retrospective and then prospective components. So as I indicated earlier on to Easter, the prospective and retrospective designs are the same. The only difference is the calendar time. So what are the limitations of a retrospective cohort study? The available data, you realize that here we are assessing existing records, the exposure data from the factory, and then also the medical data from the hospital. And you know, in our part of the world, in sub-Saharan Africa, in South Asia, we have very poor record keeping. So if you are using this design, there is a tendency that you might encounter poor quality of data. So the available data may be of poor quality if original study was not designed to investigate the present relationship. So you realize that in the factory, that the information that they provide you is all going to be paper. Some of the information will be lost. And this is where you have to draw on your biostatistic skills to maybe possibly do some data imputation. I'm hoping the people that will come after me to do the biostats and stuff will expose you to some of these data imputation techniques. Often the absence of data on potential confounding factors. Because you have, I think we established that to collect information on these potential confounders, it means you must have perused the literature and identify those that are associated with the exposure and the outcome, and set up your study and have a data sheet that goes to collect this information. So if you are doing a prospective cohort study, it's not likely you get information on all the potential confounding factors. So that is also going to be problematic. So you are going to adjust, but you are not going to be able to adjust for all the potential confounders because you couldn't measure them. You know. Then there could also be something we call differential losses to follow up, which is also a problem in such cohort studies. There are two types of cohort. You have a fixed cohort and a dynamic cohort. The fixed cohort is the same as the closed population. And this can include members, let's say workers in a certain jurisdiction or in a factory at a given date. And then the dynamic cohort is where members are always being recruited into the study during the study period. So I think this is the same as what I've been talking about. So your prospective, you move from exposure to outcome. Retrospective, we are moving from exposure to outcome, but then from back in time. And then the ambidirectional, which I myself struggle to understand what it stands for, incorporates both parts, both components. But what is important to note here is that it's the calendar time that determines the two designs. Sorry. When is a cohort study warranted? When do we need a cohort study? We need a cohort study when the exposure suspected as a possible cause of disease is known. If you don't know the exposure, why are you setting up a cohort study? You have a hypothesis. And then you have observed, and you realize that smoking will be a potential cause of lung cancer. Then you set up a study. But the beauty of cohort studies is that it allows you to also assess multiple exposures. It allows you to assess time-varying covariates. So there are some of the covariates or potential confounders that vary over time. And even time-varying exposures. The exposures could vary over time. You know, today, if I have money in my undergraduate class, that's the example I always give. Today, if I have money, I can smoke 2 cigarettes. Tomorrow, I don't have money, I'm smoking 1 cigarette. Maybe next month, I won a lottery, so I can smoke 5 packets of cigarettes. So these are time-varying exposures. And the beauty about cohort studies is that you are able to make accurate measurement of these time-varying exposures. But the starting point is that a cohort study can always be applied when you know the exposures. And also we advise, I know there are some cohort studies that are still running. You know, there are some cohorts that are still running. There are studies that followed people for 50 years. But the advice is always to have a short time between the exposure and then the development of diseases. What I think in infectious disease, they call the latency period. It needs to be short. Why do you think we always advise that the latency should be short? Why do you think we advise that you should use a cohort study for diseases where the latency period is short? Why do we advise that? Who can help us? Yes, I'm listening.
I think it's because you want to reduce the loss to follow-up.
Oh, great. That's the reason. We want to reduce the loss to follow-up. If you are following people, Noah, you wanted to say something? I see Noah talking.
Yeah, also to reduce the impact of confounding variables in the study.
Yeah, but basically, go ahead. You go ahead. I don't want to catch you. Yeah.
With the long duration of the follow-up, a lot of confounders may come into place, which maybe at the beginning we are able to control, but as the duration goes, the confounding effect, other factors may come in and you will not be able to control those confounders. So a short period of follow-up is necessary in cohort studies.
Okay, you could be right, but I was thinking that the confounders, we have already determined that at the start of the study, that these are our potential confounders and we are collecting data at all the time points. Yeah, but that is also well noted. But the key
Prof,
thing here.
I wanted to find out, what about the cost implication? Can it be also the reason for shortening the period?
You know, we are not necessarily saying shorten the period. You know, so if you want to study smoking and lung cancer, you should understand that you could keep people in this cohort for about 25 to 30 years. Because these things don't develop overnight. There are people that have been smoking over 50 years, they still don't get a disease. So, and if you want to set up a cohort study, you know it's resource intensive. You need huge capital, huge amount of resources, money, to be able to set up a cohort study and follow them over time, you know. So yes, you could be thinking about the costs, but the key thing here is that we want to minimize the attrition. There's cohort studies, data from cohort studies that have been published where the response rate is about 50%. Anything less than 70%, there are serious validity implications. I hope we are able to get into those things. Like there could be selection bias, you know. So basically, you should be using them for diseases where there is a short latency period as it relates to the exposure. But that notwithstanding, there are cohort studies that are still ongoing. And the beauty about cohort studies, those that are still ongoing, like the Norwegian mother and MOBA, Avon, and all those things that are out there, is that you realize that the people that even set up the cohort study, they are dead and gone. But people are now investigating different outcomes and establishing, measuring different exposures out of these cohort study. But you realize that often they present and then the response rate is very, very low. Then also, if the exposure is rare, the exposure is not common in the population, then a cohort study is the best. And I have talked about the last part, where it enables us to examine multiple effects of the exposure, as well as also measuring time-varying covariates. Case control study was described by my friend. You know, what he said was that you pick cases, you usually go to a hospital, you pick cases, lung cancer cases, then you go to another department in the hospital, and then you go and pick suitable controls. These controls must not have lung cancer. So these are the diseased individuals and then the non-diseased individuals respectively. And then we assess their exposure history. So you have a questionnaire and you use it to assess their exposure history. Have you been eating dietary fiber? Yes and no. Or have you been smoking? Yes and no. And then we compare. We compare the prevalence of disease between the two groups, the cases, and then prevalence of exposure between the two groups, the cases, and then the disease. It's a design that is mostly used together with cross-sectional studies because it's less time consuming and it's less costly than the prospective cohort study. You don't need any follow-up time, and so there's nothing like attrition for you to be worried about. But I must emphasize that what I have described is the traditional case control studies. There are variants of the case control studies. So this one is what we sometimes call the cumulative case control study or the prevalence case control study, because here we are interested in existing cases. But you can also have cohort studies which are nested in a cohort. So you have a cohort study running, and then we can nest a case control study in there. That one we are dealing with incident cases. And that is what usually we call the incident case control study or the nested case control study. I have a slide on that, so I'll come there. First, let's look at how we select controls. So your controls should be representative of the source population that produced the cases. And this is to help minimize selection bias. So usually in the EPI books, you see that it should come from the same study base. So the same study base that produces the cases, it should be the same study base that is producing the controls. You can, and it's possible to select your controls from the same hospital where you get a case. But if you are not getting them, you can source community controls. So you are getting controls from the community which produces the cases. So if you set up a case control study in my Cape Coast area here, and you are picking the cases from, let's say, the main hospitals, the 3 main hospitals here, you could decide to use community controls. So the community controls will come from the suburbs in Cape Coast, but you cannot go and get the controls from Accra. This is what we are trying to emphasize here. So here, this is a typical case control study. So you have cases, you have controls. Among the cases, who is exposed, who is non-exposed, and then we are interested in the exposure odds among diseased people, exposure odds among controls, and then we compare the exposure odds, and then we have something we call odds ratio, which I'm sure is a term that everybody on this call has heard about. It's about the same thing. So you have a population of cases, then you sample some cases, you have a population of controls, you sample the controls, and then you assess their exposure history. I think what this schema talks about is you can assess the exposure history, whether presently or in the past, but the focus should be on past exposures. So yes or no, and then you compare the exposure odds between the two groups. So this compares the two. So you have cohort study, you have exposed, non-exposed, you follow them up, and then you compare incidence. For case control study, you have disease. So one is forward, one is backwards. As you can see, you have diseased people and then non-diseased people, and then you compare their exposure histories. When do we need a case control study? When the outcome is rare. When the outcome is rare, there is no point doing a cohort study. It's just a waste of everybody's time and resources. So when you know that the outcome is rare, you can use a case control study to establish whether there's a relationship between the exposure and the outcome. When the outcome has a long latency period, long time between exposure and the eventual causal manifestation of disease, which I have talked about, you don't have to bother to use a cohort study. Again, it's going to be a waste of money and resources. When exposure data is difficult or expensive to obtain, if you want to set up a study where you are measuring multiple biomarkers, you are doing vitamin D assays, it's very expensive. You don't have the resources. You are not going to sit around and cry. So you can go to case control study to establish your relationship. And then when the study population is dynamic, people are moving in and out. It's not a fixed cohort. People are moving in and out. If you set up a cohort in a very dynamic population, what do you expect? What are we going to see? If we set up a cohort study in a very dynamic population, I think we have already answered this. I just want to see whether you are still awake. What are we going to see?
A lot of loss to follow-up participants.
A lot of loss to follow up, yeah. And when little is known about the risk factors for disease, when we know very little about risk factors for disease, we can set up a cohort study. So more or less, it becomes a hypothesis generation thing we are doing. We want to generate an association, and then if we can generate a hypothesis, just like we do with cross-sectional studies. And if we can find big money, then we can set up a cohort. So this is what I was trying to talk about. We have case-based cohort control studies. In the mainstream epi books, you might not see this classification or distinction, but in the advanced books, you see this distinction. So the case-based is just like the traditional case control study that I have outlined to you. Then the cohort-based case control studies are the nested case control studies. And the difference is just based on the approach for selecting controls. So in the nested case control study, we use something we call risk set sampling, risk-set sampling. So in a typical nested control study, we have a cohort running, and then a case develops. So we are following people over 50 years to see who gets lung cancer. Then at some point, we get lung cancer case. So when we get lung cancer case, then the risk set, we identify a suitable control. It could be 1, 2, or 3 controls. In a cohort study, in a case control study, you can select multiple controls, but we don't advise going more than 10. Once you go more than 10, there is no statistical efficiency gain. So in the risk set, once we get a case, we don't follow that case again. So what is left is the risk set. That risk set, we identify a suitable control. But what you need to keep in mind is that that control we have identified for this case can also potentially become a case, because we leave the person in the risk set and we are going to follow that person up. And this control could potentially in the next 5 or 2 years also become a case, and we identify a suitable control for that case. We assemble them and then we compute. But here, when you compute your odds ratio, that odds ratio is a risk ratio. It's a risk ratio because we are dealing with incident cases and not prevalent cases. I hope I'm very clear on this. Do I get a yes?
Hi, Prof. Can you please repeat that?
Okay, sure. So is one second, please. Hello, Thomas. Yes, sir. Yeah, so let me repeat it again. So you have a cohort study, and the way a cohort study is set up is you have exposed group, you have unexposed group, and you are following this for 50 years. Okay. Then at some point, an exposed person gets the disease. So this is an incident case. So if you want to do a nested case control study, what happens is that this case that we have identified, so this case, this group, this exposed person that we have been following, after 1 year gets lung cancer. So this case number one, that case number one, we look within that risk set, and that risk set encompasses both the exposed and the unexposed group, the total population. We look within that total population, and then we identify a suitable control. The reason why I use the word a suitable control is that sometimes we could be doing matching. We want to match the case to the control. I'll talk about match case control studies very shortly. We want to do matching. And when you want to do matching, possibly you want to identify a suitable control, a control that has the same age as the case, and also lives in the same location, and also has the same race. So we identify a suitable control in this risk set. So now we have a case, we have a control. Then we allow that control to be in that risk set because this control hasn't developed the disease. Once you haven't developed the disease, once you are not lost to follow up, we are following you till we end the study. Not until we terminate the study, everybody is at risk of disease. What I just wanted you to keep in mind is that this control that we selected for case one also has the potential to become a case. And when that control becomes a case, then we also have to look in that risk set and identify a suitable control for that case. Is it clear now, please?
Yes, I wanted to clarify. So when you report the results, do you only, for case control studies, is it appropriate to report odds ratios, or you only report risk ratios? Which one is more appropriate?
So when we do measures, we'll talk about that. Oh. You know, in a prevalence or cumulative case control studies, you are reporting odds ratios because it's a prevalence study. You are not measuring risk of disease. It's not incidence, disease incident. So that is an odds ratio. But if it's an incident case control study, or what we call the nested case control study, then your odds ratio approximates the risk ratio. So what you are reporting, you can compute the odds ratio, you can also compute the risk ratio, and it should be the same. They should coincide. But again, in a case control study, if the outcomes are rare, if the outcomes are not common in the population and the threshold is 30%, your odds ratio should approximate your risk ratio, something we call the approximation of the odds ratio to the risk ratio based on the Kofi assumptions. But here, what I want you to understand is the technicalities involved in a nested case control study. And maybe just to get you to better appreciate it, a nested case control study is often done in a cohort study that has ended. maybe a cohort study has ended after 20 years, and then somebody wants to establish a relationship but wants to use the nested case control study. So he will identify all the cases and identify a suitable control because the data is there. Or maybe you have case control studies that have been running. I mean, most of you have cohort studies that have been running in your locations, you know, MOBA, the Avon, the ESPO cohort in Finland and others that have been running. So maybe they have run for about 5-10 years. Then you want to investigate some relationship, but you want to use the incident case control study. So you can appeal to that data and get that information. Can we make progress? Have I answered your question?
I have a follow-up question, Prof.
Okay, yeah. Hello, Steven. Go ahead.
Yeah, being an infectious disease epidemiologist, if I have a surveillance data for a number of years, let's say 5 years surveillance data, maybe yellow fever or Lassa fever, is it possible for me to design a case control from that kind of data where I have positive or negative for maybe yellow fever or Lassa fever?
That surveillance data is prevalent cases, not incident cases. Yes.
Yeah.
So you can't develop a nested case control study. Nested case control study is nested in a cohort. And the way we set up a cohort is that you need to have exposed group, unexposed group, and you are following them over time. When they develop the disease, you identify a suitable control. So your surveillance data are prevalent cases, so you can't have a nested case control study in there. And the reason why you can also not have, well, you can set up a cohort, a case control study. Let's look at it from this angle. So this surveillance data as whether you have Lassa fever or you do not. Do you have data on their exposures?
Yeah, there are social demographics, clinical characteristics.
Yeah, then sure. So once you have that, then you'll be able to, you can set up a traditional case control study. So this traditional case control study is nested in a surveillance, I don't know, surveillance system. Maybe that's what we want to put it, right?
Yeah.
Yeah. So it becomes a traditional case control study, but here you are not in contact with the persons. And you have information on those who did not have contract the Lassa fever, isn't it?
Yes.
Yes. So then those who had the Lassa fever becomes your cases. Those who do not have the Lassa fever becomes your controls. And then you can appeal to the historical information on their exposures and then assess their exposure history. That would be a brilliant study to work with.
Yeah.
Yeah.
Yeah, thank you, Prof.
Yes, and don't forget to acknowledge me if you publish that paper. Anyway, any other questions? Okay, so let's boss on then. Oh, and this thing is not moving. Can you hear me?
Yes.
Yes.
Yeah, my slide is not moving. Okay, let me stop sharing and then start again. Okay. Okay, so cross-sectional study, that one I'm sure everybody on this call knows. So you have your reference population at a particular point in time, and then you assess exposure and outcomes at the same point in time. So you could just go to your population, you want to investigate the relationship between, let's say, what do I say? What can we investigate? Hypertension. Let's say hypertension and diet. Hypertension and salt intake. So we are interested in, and let me indicate that cross-sectional studies are used to generate hypotheses. So hypertension and salt intake. So you just go to a defined population and then you draw a sample, and then you have your questionnaire. And then the question is, do you have hypertension or not? Yes and no. Just as they do with DHS studies. Do you have hypertension or not? And then do you take in salt or you don't take in salt? Or how much salt are you taking? You have that data. So you're assessing exposures and outcome at the same point in time. And here you compute something we call prevalence ratios. It's the same thing, odds ratio, but here normally we call them prevalence ratios. And that's the reason why we also sometimes call it prevalence study. The caveat here is that any association that you observe in a cross-sectional study may be with survivor rather than risk of developing disease. Because the people you are encountering possibly are surviving the disease. They have developed some survival mechanisms. So that's the reason why you can't use the language of risk in these studies. So whatever you are seeing might be due to survival, but not the risk of diseases. But they have survived, and it's prevalence data. Some might have contracted the disease and must have died. The people that are surviving, maybe they have some genetic constitution that is enabling them to survive or confer survivor. So what you are seeing might be due to survivor, but not the risk of developing disease. The main limitation with this design, just as it is with the traditional case control, is something we call lack of temporality. We are not able to establish a temporal sequence. What that means is that we are not able to establish whether the exposure preceded the disease. And that is the more reason why the cohort study is the most rigorous epidemiological design or observational design. Of course, the intervention studies, the control trials, randomized control trials are the gold standards. But if you come to the observational designs, and you know, not all the exposures that you can, it's unethical. For example, to go and assign people to smoke. It's unethical for you to go and assign some people to go and expose themselves to cooking smoke or air pollution. You know, so not all the relationship that we can elucidate with an intervention study. So the cohort study remains the most rigorous of the epidemiological design. And what confers that robustness is the fact that we are able to establish temporal sequence. We are assembling people based on exposure, and then we are following them to get disease. But if you look at cross-sectional study or case control study, the disease has already happened. The disease has already happened. Case control study, you are assembling people based on disease and non-disease. Cross-sectional studies, you are assessing exposures and outcomes at the same point in time. And these are prevalent cases. So how sure are we that indeed the exposure preceded the disease? Is it not the exposure, people not being exposed after they have gotten the disease? So this is something that is difficult for us to ascertain in a cross-sectional study and also in a case control study. And this is one of the main criteria for establishing causality. If indeed you want to move from association to causality, we need to be able to establish temporal sequence. Those of you who have had exposure to epidemiology and you know the Bradford Hill criteria, you know it's one of the things you have to satisfy. Besides the consistency, strength of evidence, and blah, 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 biological gradient and stuff. It's one of the things that you have to satisfy. So because of this limitation, when association is found with cross-sectional designs, we have to rely on rigorous designs, such as the cohort, and then the incident case control studies to establish causal relationship or etiologic relationship. I'm going to end on ecologic studies, which I'm sure, let's find out from people on the call. Who wants to describe an ecologic study to us? Somebody who close in the next 5 or 10 minutes, we can break for about an hour and then come back. Who wants to describe an ecologic study to us? Anybody wants to describe ecologic study to us?
I'll try.
Humphrey. Yeah, Easter. Okay, then Easter first, and then Humphrey.
So it basically aims to describe the relationship between exposure and outcome, but the unit of observation is normally a population or a community.
Okay, great. Humphrey, do you have anything different?
No, it's the same thing. So I actually wanted to say that this is going to be on a population level other than an individual level.
An individual,
and also
absolutely.
an observational study design.
Yeah, okay. So it's also one of the observational study designs. But here, the association that you are describing is at a population level and not an individual level. But it has a problem. It has a problem. The problem is that variability between the individuals is not taken into account by this design, and something we call ecological fallacy. So you are ascribing things to a group, you know, so that is what you are doing. Simply, we may be ascribing members of a group or characteristics that they do not in fact possess as individuals. So it's group level. So you have boxed everybody together. You have boxed everybody together. And that is the main problem with ecologic studies. So if you look at this is correlation between dietary fat intake and breast cancer by country. So what you can see here is that as per capita supply of fat, calories is increasing, incidence of breast cancer is also increasing among women. You see a very strong monotonic relationship. But then, is there a relationship between breast cancer incidence and dietary fat consumption by country? From the graph, we see that as average dietary fat consumption increases, breast cancer incidence also increases. What is wrong with this data? The problem is ecologic fallacy. The problem here is ecologic fallacy. So there are individual variability in the consumption of fat. But what we are doing here is that we have boxed everybody together in a country and thinking that all Americans are eating the same quantity of fat. All Spanish people or Finnish people are eating the same quantity of fat, you know. And so this is where we have the ecologic fallacy. That is my last slide. And these are questions to guide the selection of study type. So if you have a hypothesis which you want to investigate, how do you choose a study design? I picked this somewhere from the internet. What is already known about the exposure disease association is very critical. What I want us to do in the next 5 minutes before we close is that I'm going to take each of these points and then just get a quick reflection from everyone on why this is important for selecting a study design. So the first one, what is already known about exposure disease association? Why is this critical to choosing a study design? Why is this critical to choosing a study design? We can do this quickly in 5 minutes, then we can close. Yes, I don't want the same suspects. There are many others on the call who haven't spoken. I want to hear their voice. Is Equian Ponsa on the call? Anybody call Equian Ponsa on the call? Okay, who wants to start? Why is this critical to selecting a study design?
Can I say something?
Maria.
Okay.
Yeah, please go ahead.
Yeah.
Maria before Steven.
So
Okay, it is very important for us to select the appropriate study design. Number one, because of inferential purpose. We are going to make inferences from the data that is being collected. So we need to get the correct population, select the correct variables to make that inferences. And then for ethical reasons, I think it's very unethical to bring patients or study participants together for something that will not yield to the eventual goal, which is to solve public health problems. So for that reasons, I feel it's very important for us to select the appropriate study type.
Yeah, Stephen, what do you want to say before I summarize?
Okay, and just to add, I think it's important to look at the literature, to look at what is already known about the association, so that maybe we don't want to waste resources. If the study has been adequately conducted, there is no need to waste resources on what has been previously known.
Richmond, you have your hand up. Hello, Richmond. Okay, so all the information is good. What I just want to add up is that what is already known about exposure disease association. If all the evidence out there have used a cross-sectional design, a case control study design, in summary, they have used a prevalent study design. Then if you are using a cross-sectional, or if you choose to use a cross-sectional or a case control study design, then you are not contributing much to the literature, isn't it? Yes or no? Do we agree?
Yes, please.
Yeah. Yes.
You are not contributing much to the literature. You could sometimes, often what we argue is that, oh, my data is coming from Ghana. Nobody has conducted that study in Ghana. My data is coming from India. It's coming from Nigeria. Nobody has conducted that. Do we need to conduct studies in every country before we put in an intervention? Please, can anybody answer? Don't we already know that smoking causes lung cancer?
Yes.
We do know.
We know. We do know. Why do we have to
Yes.
conduct a study in Ghana today or tomorrow on lung cancer and smoking before we put in an intervention in Ghana to address lung cancer? So you see, it doesn't make sense. So if you want to contribute to the literature, then you need to identify the exposure disease relationship. You need to also understand the direction. Maybe all the studies out there, the direction is that the exposure, the association is protective. They found a protective association. It means the exposure is not a risk factor. So that way, you want to see, you still want to stretch the argument. But importantly, if all the studies out there are using cross-sectional studies, you don't contribute anything to the literature, even when your data is coming from heaven. You can only make meaningful contribution to the literature if you choose a prospective study design. And that is the more reason why we want you to do this. How common is the disease? How common is the exposure? That one is in the notes that we have all reviewed. The other one is, do you have access to the study population? Why is this very important? And why should this inform the design? Do you have access to the study population? Why is this important? And why should this inform the design? Especially, what design will you choose? Do we have anybody, Mauli Gohoho, on the call? Mauli Gohoho.
Yes, Prof.
Mauli, please answer this question for me, if you don't mind.
Okay, Prof. I think having access to the study population is very important to the design. That is to say, for example,
and we conducted a study to assess the intention of students to vaccinate against COVID-19. And the problem was highly prevalent among students. So we targeted the senior high schools. So then this population were readily available for us to go in there and then obtain our data and make statistical inferences from this.
Anybody has something else to say before I come in?
I think access directly influences the sample size and the statistical power. That will be useful when we talk about validity and of course generalizing the data to the study population in the future. Yes.
Okay. So it's all good information you've provided. But
Hello,
what
Prof.
I want to keep, yeah, go ahead.
Yeah, I think knowing your study population will help you to know the sampling approach that and the sampling and recruitment approach that you should take. Let's say if you are dealing with an event or a condition that is very rare, it will inform you how you are going to go about the sampling. Because if it is not readily available, the population is not readily available or known, you can't just, let me say, go in or adapt any design that design or use a design that at the end of the day, it will not allow you to select or recruit the people that you may want to be part of the study. So it's very important to take note of your study population before you think of the design.
Okay, that's fine. That's fine. It's all good points. But what is missing is that if you want to do a case control study, you want to use a case control study to examine your relationship. Are they going to allow you to work in that hospital? Are they going to allow you to come in contact with people that are chronically or critically ill? So this should be some of the guiding questions. If not, is there a way you can do this study in a community using a different design? So these are things that it needs to be guided by, in addition to what you have also indicated to us. Then the budget and resources is very clear. If you don't have money, you don't go and set up a cohort study. And then how pressing is the need to control the disease? That is the last one I want us to answer. This borders on public health prevention. How pressing is the need to control the disease? Why should this inform study selection, study design selection? How pressing is the need to control disease? Okay, so in the interest of time, if you have a number of diseases out there that is impacting the population, that we want to put in a quick intervention, but we want some evidence. So we are seeing some disease in the community. We have no information what the etiologic factors are. We have no information what the risk factors are. And it's killing a lot of people. There's a lot of fatal outcomes. Why do we want to go and set up a cohort study that will take us 5-10 years? Please, are you with me? Why do you want to go and set up a cohort study that will take 5 to 10 years? We can quickly use a cross-sectional design to establish the relationship and put in a quick intervention. I hope you all agree with me.
Yes, Prof.
Yes, Prof.
Thank you very much. On that basis, that is the end of the lecture for today. But please, morning. Okay.
Good afternoon, Prof.
Yeah, good to be back. Let's hope I have the energy to sustain another 2 hours. We'll see. Okay. To share screen. So for the next 2 sessions, I I have a lot of slides. I've tried to distill the notes that I used to teach, but I still have a lot. I think in total, I have about 80 slides. So we will rush through. I've exposed you to the discipline of epidemiology. We've looked at study designs. The approach, as we all agreed in the morning, was that you need to identify a suitable study design to investigate whatever hypothesis that you have. So once you have a design, then the process with any research exercise is you have to collect some data. And then once you collect the data, then we need to test the hypothesis to see whether indeed we need to test to see whether indeed the exposure that we have in mind is associated with the disease. So this is what we call measures of disease occurrence and then also measures of association. So the disease occurrence, we want to try and establish the prevalence and then the incidence of disease in the population or in the cohorts that we have assembled. And then also the measure of effect. So the measure of effect is what quantifies the relationship between the exposure and an outcome. Simply, we move from measures of disease frequency or measures of occurrence to measures of effect. And then from measures of effect, we move into measures of potential impact, what we call the attributable fraction. What that means is that we want to try and establish whether if we remove the exposure from the population, how many people do we save from getting the disease? So if you cut the exposure from the population, how many people do we prevent from getting the disease? And usually in any epidemiological study, you also have to endeavor to estimate the attributable fraction. So this is a schema that summarizes everything. We are moving from a measure of disease frequency, which is incidence and prevalence. And the incidence, we have cumulative incidence, which is based on persons at risk of the disease. It's based on persons at risk of the disease. Then we also have incidence density or incident rate. And that is based on your person time of observation. I'll try and explain all those things. Then in the prevalence, we have point prevalence, period prevalence. Then we have the measures of association, which is and that one we have the absolute difference, and then we have the relative difference. So the absolute difference, one incidence ratio from the other, and then you have the relative differences where you are dividing one incidence ratio by the other. You have relative differences where you are comparing the two incidence ratios or rates in the exposed and unexposed, and then you have a number of them, but collectively they are called a relative risk. So whenever you say relative risk, for me, it doesn't mean anything. I don't know whether you are talking about risk ratios or rate ratios or odds ratios or prevalence ratios. The textbooks sometimes are very confusing. I mean, they tend to make it seem as if relative risk covers the risk ratios or the rate ratios, but it's a collective term for all the ratio measures. Then I talked about the measures of impact. So here you have the attributable risk and the excess risk, and then the proportions as well. Conical flags illustrate everything perfectly. So in every population, you have people that have the diseases. So if it's lung cancer and in a population of, let's say, Lagos, you have people in the population that have lung cancer. So this is prevalence. And then you have new cases coming in. And so that new cases is what you see. And that is incidence of disease. So those are new cases. Then you have people that are either getting a cure or they are dying. So these people continue to filter out of the population, and the new cases are coming in. And what is existing is the prevalence cases. So what is risk? Risk is the probability of an adverse or beneficial event in a defined population over a specific period of time, specific time interval. So risk is a probability. And that is the more reason why often we try to caution that we don't have to interchange odds with risk. Risk is a probability, odds is not. You know, the difficulty with teaching this component of the course is the writing. We don't have a board. And I don't want to switch between the whiteboard, because interference with this thing. So I'll manage what we can do here. And in EPI, it is commonly measured through the cumulative incidence. So risk is a probability. So then I said we have incidence that is based on persons at risk. So the denominator is the persons at risk. And then we have incidence that is based on person time of observation. So I just want to situate everything in a cohort study. So in a cohort study, you assemble people based on their exposure. So you have an exposed population, and then you have an unexposed population. And then you follow them up for, let's say, 5 years. So whilst following them up for 5 years, there is a number of them that will get a disease. There are others that will not get a disease. So among the exposed group, if you want the incidence of disease among the exposed group, then is the number that had the disease divided by the population, the total number of people that you assembled. Please, is it clear? I don't want to switch between the board and this because it interferes. So divided by the total number of people. But that total number of people, we want the persons that were at risk. We want the persons that were at risk. So for example, if there was an attrition, it means that person was not at risk. If there was a death during the period of follow-up, that person was not at risk. So in computing the cumulative incidence, we need complete follow-up of every individual in the cohort, where the cumulative incidence is estimated as a number of disease occurring during the follow-up divided by the initial population at risk. So this is what I try to explain. So this is what happens. So if you want to undertake a cohort study, so you initially identify a population, then you have to ensure that you have removed all the prevalent cases. Because if you have prevalent cases there, these people are not likely to, they are not going to develop the disease. They already have the disease. So you ensure that you don't assemble people that already have the disease in the cohort. And then you follow up. And then once you follow up, then we look at who has the disease, who did not have the disease. So this is typically how we represent a prospective cohort. So we have subject A to L, and we are following them up. Let me see. Yeah, we are following them up for some number of years. So let's say we recruited subject A in 1981. We recruited subject A in 1981. And then we are following them up for 15 years or 14 years. So from 1981 to 1995. Subject A at some point was lost to follow up, either lost to follow up or died. So you realize that he or she did not complete the study. And then for subject B, he or she got a disease in 1992. So this is how a follow-up study is. So what we do here is that from subject A to L, we segregate them. We separate them into those who are exposed and those who are not exposed. And then we can calculate incidence of disease among the exposed, and then also incidence of disease among those who are not exposed. But what I try to indicate is that when you are calculating, the denominator is the persons at risk. So you need to ensure that those that were lost to follow-up that were either in the control group or the exposed group, they are taken away from the denominator because they are not at risk of the disease. Some of the textbook, the advanced textbook like SASCLU, prescribes that rather than taking those people that were lost to follow-up completely, we can just take half because there were some number of years or number of months that they contributed time to the study. So those ones, we need to take care. We need to consider that in the denominator. And that is the reason why the incident rate, where the denominator is person time of observation, takes care of these problems that we have. Then we have measures of prevalence. So here is existing cases. So if the prevalence is for a particular point in time, that is point prevalence. If it's for a period, then that is the period prevalence. So here, the existing cases divided by the total number of population, and then you get your prevalence. And this is the primary measure in a cross-sectional study. And here the caution is prevalence is not a measure of risk because it does not take into account the duration of disease. If you look at incidence, we take into account the duration of disease. We are following people, and then we can compute incidence at a time point, you know, whereas here it doesn't. Existing cases divided by the total number of persons. So these are some of the factors that influences prevalence. In the interest of time, I will just skip. There's a lot to cover in the next 2 hours. Any question on incidence and prevalence? Is there any questions?
Yes,
any questions?
Yes, Prof, I have a question. I want to understand it clearly on the period prevalence, because my understanding is that should you always put time frame on this one? Because can it be for a month or?
Yeah, you have to put a time frame. So if you look at the last pointer here, when prevalence is used without any modifier, is generally referred to as a point prevalence. But for period prevalence, you need to put a time frame. That during the period of 5 years, between this year and this year, this was the prevalence of disease in the population. Is it clear?
Yes, please. Sure. Thank you.
Any other question?
Yes, Prof. You made mention of the confusion between risk and probability or odds.
Odds, yeah.
Could you clarify for them? Because I think I've seen that in a number of papers, maybe kind of using them interchangeably, something like that.
Yeah, so you know probability is so the probability of, let's say, you getting ahead when you toss a coin is half. So the number of outcomes divided by the total of outcomes, you know, so usually we denote it by, so if you have probability equals to P, then the probability of the event not happening is Q. And probability adds up to 1. So the probability of the event not happening, Q, is 1 minus Q. So if you want the odds of the event happening, the odds of the event is the probability of the event happening divided by the probability of the event not happening. So that is P over Q. So this is odds. But risk is a probability measure. So that is what risk is. You know, so when you have in the medical literature, the confusion there is that you have people that are computing odds ratios and then they are interpreting them as risk, which is wrong.
Risk. Yeah.
Yes, which is wrong. You need to interpret them as odds because they are not probability measures.
Okay.
You know, but let's focus on this one. I'm sure when we get deep here, I mean, it will shed more light on this. So as I've said, the measure of effect is a quantity. So here you are trying to quantify the strength of the association between your exposure variable and your outcome variable. And as I indicated with the schema, you have ratio measures, and then you also have difference measures. So the difference measures are your risk ratio, risk difference, and then the rate difference, or what we call the excess risk. And then your ratio measures are your risk ratios, your rate ratios, your odds ratios, your prevalence ratios, and which collectively are called are called relative risk. But also your regression coefficients that you generate in your linear regression models, they are all measures of effect. But here specifically your regression coefficients, the betas, are measures of effect. So incidence of disease in a population is what we term absolute risk. And that is what indicates the magnitude of risk in a group of people with a certain exposure. And the risk here is what I said is a probability measure. So your absolute risk here, so let me go back. The incidence of disease in the population. So here, the general population. So the incidence of disease in a population is what we term the absolute risk. So the general population. So you can compute incidence of disease for the general population. So even though you assemble a cohort based on exposed and unexposed, you can decide to compute incidence of disease for the entire population. But what you need to keep in mind is that the absolute risk does not take into account the risk of disease in unexposed individuals. So we need to find a way and separate that. We need to find a way and separate that. Once we separate that, then we are able to quantify the strength of relationship between the exposure and the outcome. So if you don't separate that, then you cannot indicate whether exposure is associated with increased risk of disease. So to determine that, to overcome that, we must establish whether there is an excess risk of disease in the exposed group. So if you remember in the morning session, what I said was that we all have a baseline risk of disease. If it's lung cancer, we all have a certain baseline risk of lung cancer. It could be based on our genetic composition or constitution. But what we are interested in is the excess risk among exposed people. So the excess risk is that if you are smoking, that is the excess risk that we want to separate. So maybe the excess risk is higher among exposed groups. So when you subtract, if you are using an absolute measure and you subtract, then that gives us the excess risk. So it's the excess risk that more or less quantifies the strength of the relationship. And the excess risk is always easy to determine. You compute your incidence among exposed, and then you compute your incidence in the counterfactual. The counterfactual is the unexposed. So if you subtract the unexposed incidence from the exposed incidence, then you should be able to have that excess risk. And that excess risk is what is going to tell us whether indeed the exposure is associated with the outcome. This is where I wish I had a board and then we can do things. But let's see, I have this slide here, yeah, which I can use to shed more light. Rather than this gets a bit confusing. Okay. So when you have a cohort study, this is a typical setup for a cohort study. You have the exposed group and then you have the non-exposed group. And then you are following them up for, let's say, 20 years. Among the exposed group, who has the disease, who does not have the disease? Among the exposed group, who has the disease, who does not have the disease? So among the exposed group, those who develop the disease, we represent them as A. Those who do not develop the disease, we represent them as B. Among the non-exposed group, those who develop the disease, we represent them as C. Those who do not develop the disease, we represent them as D. So if you want the total number of exposed individuals is A plus B. Do we all agree?
Yes, Prof. Yes, Prof.
Thank you. If we want the total number of non-exposed individual in this cohort is C plus D. So therefore, folks, if you want the incidence of disease among the exposed cohort, is A divided by A over B. And if you want the incidence of disease among the non-exposed cohort, is C divided by C over D. C is the number of people who have the disease, and then C plus D is the total. So incidence of disease in exposed group, incidence of disease in non-exposed group. You have it there. But this is where I said that There could be some attrition. So in the denominator, we need to find a way to remove that attrition from the denominator, because those that were lost to follow-up were not at risk of disease throughout the entire duration of the study. So we need to find a way to remove them from the denominator. But the incident rate helps us to surmount such challenges. So going back, this is what you see here. So if you want the risk difference, that is the absolute measure or the excess risk, then you have to subtract C divided by C from plus D from A divided by A over B. Please, you get me? So that is incidence among the exposed minus incidence among the unexposed will give you our risk difference. Is that clear, please?
Yes, sir.
Okay,
Yes,
thank you,
please.
sir. Okay. And then if we want the risk ratio, which is a ratio measure, then what you have to do is that you divide incidence in exposed by incidence in non-exposed. So incidence in exposed usually we denote as I subscript E. And then incidence in non-exposed we denote as I subscript 0. So once you divide that, you get your risk ratio, which you can interpret as a risk. Exposed group have 1.3 increased risk of disease compared to non-exposed group. So this is how we test hypothesis using our relative risk. So when you have relative risk of 1, that is when you divide IE by I naught, and you have a relative risk, a risk ratio of 1, it means there is no excess risk due to exposure. It means the risk in exposed people is same as risk in unexposed people. There is no association between the exposure and the disease. So that is the null. The null is 1.00. H naught is 1.00. And if you have a risk ratio which is greater than 1, then you we put possibly causal there because here is an association. Of less than 1, then there's the exposure is protective. It's a negative association. That's what you see, possibly protective. So it means the exposed population have a decreased risk of disease compared to the unexposed population. Concept of odds. So in a case control study, you don't know the incidence of disease in the exposed and unexposed population. So that is the reason why we use the concept of odds, which is used in betting. In the UK, they bet a lot. So that odds, I'm told, I read, it comes from this betting schemes in the UK. So as I indicated earlier, odds is the ratio of probability of an event occurring to the probability of the event not occurring. So the probability of is P. So let's by P. Adds up to 1. So if you want the odds of getting 1 on that die toss, is P over Q. And the quotient down there is those with probability. Are we all happy or okay up to this stage?
Question.
Yes, Esther, go ahead.
You mentioned the issue of attrition in the previous slide and how that affects the denominator. I'm a bit confused because I think that is the point where the type of analysis comes in, where you talk about intention to treat or per protocol analysis.
Absolutely, per protocol and then intention to treat. Yeah.
But I've gotten a bit confused about
you have brought in the two, the per protocol and intention to treat. Intention to treat means once randomized, analyze everything. So the rate ratios is an intention to treat analysis. I think I have slides on the let me see where it is. Oh, I don't have it here. So it means I have to go back. Sorry. So I'll go back and talk about that. So yeah, it should have been here. I've skipped it. Yeah. Okay. So the per protocol analysis is that you take the attritions from the denominator. And when you do that, your estimate is biased because you have broken the randomization sequence. And that is what the intention to treat analysis solves. So let me come back here, please. Usually these ones, I do it on the board, but because I'm doing it on here, so let's stay here and then I'll take up your question again, Easter. So at least everybody knows how to calculate cumulative incidence. Now, what I want to teach you to calculate is the incidence rate. So now, if you take the exposed population, A plus B, that exposed population, each individual there will contribute some time to the study, whether they complete the study or not, whether they get lost to follow up or not, whether they die or they don't die, whether they get the disease or they don't get the disease. Same holds for each individual in the non-exposed population. So we can try to estimate their person time to the population, and that is what we call P1, PT. The total is PT. And then we can, for the exposed group, we can estimate their person years or person time to the study. That is what we call PYE. And then for the rate ratio, we call it PY naught. So when you come to this table, if you want the incident rate in the exposed group, is A divided by PY naught. If you want incidence of disease in the non-exposed group, is C divided by PYE. Sorry, the exposed group, the non-exposed group is PY naught, whereas the exposed group is PYE. Let's go here and let me try to teach you how to compute. So this is the time at risk. So if you take subject A started a study in 1981. How much time did he or she contribute to the study before exiting? 1, 2, 3, 4, 5, 6, 7, 8. 8.3 years. Please, is everybody able to follow? So 81, 82, 83, 84, 85, 86, 87, 88, 89, and something small. So 1, 2, 3, 4, 5, 6, 7, 8, 8.3. If we want the time that B contributed to the study before getting the disease, he or she was enrolled in 1981. So 1982 is 1 year. 1 year, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So she got the disease in 1992, just around 1992. So that is 11 years. Please, is this part very clear to everybody?
Yes, it's clear.
Okay, sure, great. If it's clear, then the next thing is that these subjects A to L, some of them were in the exposed cohort, some of them were in the unexposed cohort. So we can separate the exposed cohort from the unexposed cohort, so that these times that you see on the last, on my right-hand side here, you can add up the times for all those who are in the exposed cohort, and you can add up the time for all those who are in the unexposed cohort. So if you add up the times for all those who are in the exposed cohort, that is PYE. All the times for those who are in the unexposed cohort is PY0. So here, we have taken care of everybody who started the study. And that is the intention to treat analysis, if this were to be a randomized control trial. But this is not a randomized control trial, so it's not politically correct to use the word intention to treat analysis. So with this sort of analysis, we have taken care of everybody who started the study in the denominator. Even if they were in the study and they got lost for 1 month, we've taken care of them. So when you divide the incidence of disease among the exposed group divided by PYE, you get incidence rate. That is more like an instantaneous velocity in physics. If you divide this, the number of people getting the disease in unexposed group by PY0, you get incident rate of disease in the unexposed group. If you subtract the unexposed one from the exposed, you get rate difference. But if you divide the exposed by the unexposed, you get rate ratio. And that usually is in a proportion. It's usually, sorry, the incident rate is usually the incident rate among the exposed and unexposed is in a proportion. But we don't want you to report incidence rate in proportions. So we need you to report them. So here, if you look at down here, this is incidence rate for the entire population. So 3 people get a disease during the follow-up. And then the person time years they contributed to the study is 107.7. So if you divide, you get 0.28. So you did it per 1,000 or per 10,000 so that you can interpret it appropriately. So here the interpretation is that for every 1,000 people in that population, 28 will get the disease. So not in strict terms, but that is what the intention to treat analysis is. And then the other side, where we are using the persons at risk and where we have to take away the attritions, the losses from follow-up from the exposed and unexposed group, that is the per protocol analysis. And that one biases the study, biases the estimate. Have I answered your question?
Yes, thank you.
Okay, then, sure. So this is what summarizes everything there. And I think I got ahead of it. So, yeah.
Right. Yeah.
Anybody has a question? Okay, so let's continue. So we can calculate odds ratios in a cohort study as well. If you calculate odds ratios in a cohort study, that odds ratio is a risk ratio because it approximates the risk ratio. That odds ratio, if you compute that and you compute the risk ratio, you realize that they will coincide. So let's go back here. Let's go back to this table. Assuming we wanted to compute, but the question here is that what is the relevance of computing an odds ratio in a cohort study? You have a cohort study, the appropriate measure of effect is a risk ratio. So compute that. But if you are doing a nested case control study, where you are nesting a cohort, a case control in a cohort study, that is where you are forced to compute an odds ratio. And if you compute such an odds ratio, then that odds ratio approximates the risk ratio. But let's say here we wanted to compute an odds ratio. Then we are interested in odds of exposure among diseased people. Odds of exposure among those who had the disease. No, sorry. We are interested in odds of disease among exposed individuals. So what is the odds of disease among exposed individuals? That is A over B. The probability of getting the disease is A. The probability of not getting the disease is B. Please, are you with me? Is everyone with me? Okay, so if you want the odds of disease among exposed individuals, it's A over B. If you want the odds of disease among unexposed individuals, it's C over D. And odds ratio, normally, you know, cross product index, cross product ratio, AD over BC. So it's odds of disease among exposed individuals divided by odds of disease among exposed individuals. And then you get AD over BC, cross product. Okay. Then odds ratio in a case control study. Let me use this one to demonstrate. So you assemble a case control study based on diseases and assess their exposure patterns. So you have cases, those who have the disease, and then you have controls, those who do not have the disease. Among the cases, how many are exposed? That is A. Among the cases, how many are not exposed? That is C. I believe everybody can see that. Among the controls, how many are exposed? That is B. Among the controls, how many are not exposed? That is D. So in a case control study, what we are estimating is that we are estimating odds of exposure among the cases. What is the odds of exposure among cases? And what is the odds of exposure among controls? The odds of exposure among cases is A over C. Probability of getting exposure among cases is A. Probability of non-exposure among cases is C. So the odds of exposure among cases is A over C. Probability of being exposed among controls is B. Probability of not being exposed among controls is D. Odds of exposure among controls is B over D. If you want the odds ratio to quantify the relationship, then it's odds of exposure among cases divided by odds of exposure among controls, A over C divided by B over D. And that also gives you AD over BC, cross product ratio. So this is what you see there. And please, I have warned you, don't interpret odds ratios as risk ratios. So here, if you have an odds ratio of 1.2, the interpretation is that exposed individuals have 2% or 20%, 1.2 increase odds or 20% increase odds of disease compared to unexposed individuals. So odds that a case was exposed divided by odds that a control was exposed, A over C divided by B over D, it gives us AD over BC. Is everybody okay up to this stage?
Yes.
Is everybody okay up to this stage?
Yes, Prof.
Okay.
Yes.
Easter, are you happy up to this stage?
Yes, yes, I'm happy.
Okay.
Thank you.
Okay, sure. Let's continue. So this is what I talked, approximation of odds ratio to the risk ratio. So where the outcomes are rare, and the decision about rarity of disease is arbitrary. But usually in most of the textbooks, they tell you 30%. So if the prevalence of the disease in the population is less than 30%, then your odds ratios that you compute can approximate the risk ratios. We can prove that. We can prove that. And then you realize that what we get, we can prove that with data. You realize that what you get when the odds ratios, the outcomes are rare, the odds ratios that you get is going to approximate the risk ratios. And this is derived from something we call the Kofi assumption, which I think was propounded somewhere in 1959 or so. How do we calculate odds ratios in a match case control study? So there are some of the case control, there is a variant of the case control study where you match. So you pick a case and then you want to match the case to a control on certain variables. Those variables, what are they? Can somebody answer that? The matching variables, what are they? Who can help us? The matching variables.
They are potential confounders.
They are potential confounders, great. So the matching variables are potential confounders of the relationship. And often you realize that they are the socio-demographic variables, age, location, sex, race. So you pick a case, and that case lives in Cape Coast, that case is 20 years, and that case is a Black African. Then you go look for a suitable control in the same Cape Coast population, who is 20 years, who is a male, and who is a Black African. And like he indicated in the morning, you can match one case up to about 10 controls. Above 10, you don't achieve any statistical efficiency. And often what we advise is around 3 controls, 2, 3, 4 controls. It's okay. So you are matching on potential confounding variable. That means once you match on that potential confounding variable, you have control for those potential confounding variables at the design stage. So you use what we call conditional logistic regression, analyze match data and get your matched odds ratio, which is already adjusted for age, sex, and race. But when you have a match case control study, you assemble the data differently, and the odds ratio is computed based on the discordant pairs. Based on the discordant pairs. You know, so calculation of odds ratio in match pair case control study is based on the discordant pairs. This is because the concordant pairs do not provide any information as to how cases and controls differ in terms of their past exposure history. If you have, so what is, I'll come back to this. But what is a concordant pair? What is a discordant pair? So concordant pairs are pairs in which, so let me use this table rather. So this is how we assemble a matched case control study table. So you have your controls at the very top, you have your cases at the very top, and then you have exposed, unexposed, exposed, unexposed. So if you find yourself in the A box, individuals identified as A, here it means the case is exposed, the control is also exposed, the match control is also exposed. Here, the B box, the case is exposed, but the match control is not exposed. C, the case is not exposed, the match control is exposed. And D, the case is exposed, the case is not exposed, the match control is also not exposed. So A and D are the discordant pairs. A and D are the discordant pairs. They don't provide us any information as to the differences between the cases and the controls based on their past exposure histories. Whereas B and C are the discordant pairs. One is exposed, the control is not exposed. One is unexposed, the control is unexposed. So that is where we get our match odds ratios from. So the match odds ratios is B over C. So in this case, 4 divided by 1. But please take note that this is matched pairs. So each figure there, if you want the total population, the total number of people that participated in this study is this number here times 2. So 4 plus 2, 6, plus 4, 10. So if you want the total number of people in this study, it's 10 times 2, which is 20, because everybody you find there is a match pair. Is everyone okay up to this stage?
Sorry, Prof, could you repeat this match odds ratio again?
Okay. Okay, that's fine. Let's take it one more time. So what I said was that matching, there is a variant of the case control study we call matched case control study. Why matching? In the morning, we all understood that there is a third variable Z that tends to confound the relationship. And once you don't adjust for that confounding variable, then that is not the exact quantity. We don't know the exact strength or the relationship. So one of the ways that we can control for confounding is we can do that analytically in the multivariable analysis once we have all data on the covariate. Another way to do it is that you can attempt, if it's a case control study, at the design stage, you can attempt to control for this. So what you do is that you find a case, you match that case. Once you do matching, it means they are similar. The only differences between them is their exposure pattern. That is what epidemiology tries to achieve. You know, we always want to try and find a similar group, a counterfactual. So once you match, it means the case and the control are similar in every aspect, except the exposure history. So this is how we assemble that table. You have controls at the top, you have cases here. And then if case is exposed, was the control that you also identify, was that control also exposed? That is A. If case was exposed, was the control that you identify, was that control also exposed? That is B. Then you have C and you have D, same as have been explained so far. And if you want to calculate the match-odds ratios, yeah, we don't do AD over BC. Yeah, interest is in discordant pairs because that allows us, provides us information as to the separation of the cases and controls based on their exposure history. So B over C gives us the matched odds ratio. Is it clear? Have I been helpful enough? Say.
Yeah.
Okay, thank you.
Thank you.
So this is a summary of the ratio measures. In a cohort study with person times, with person at risk data, what we are computing is cumulative incidence ratio. What we are computing is cumulative incidence ratio.
Prof, it's like you are muted. We can't hear you anymore.
Just take 1 minute breather. I'll join you soon. Hello, just 1 minute breather and then I'll join you again. Oh, sorry about that. Yeah, so this is the summary. So risk ratio is cumulative incidence ratio. Risk ratio is the same as cumulative incidence ratio, and that is based on persons at risk data. What ISTA describes as the pair protocol analysis. And that is incidence among exposed divided by incidence among unexposed. And remember, or keep in mind that here, the attritions have been taken away from the denominator. Then in a cohort study, which is based on person time data, we are computing what we call a rate ratio. We are computing what we call a rate ratio. And that is incidence rate among exposed divided by incidence rate among unexposed. And remember here, the denominator is the person years or person time of exposure. And here, the denominator takes care of everybody that was in the study, what ISTA describes as the intention to treat analysis. And then in a case control study, AD over BC. I think the slides have to come and share again. Okay. In a cross-sectional study, is prevalence ratio. Cross-sectional study, you can also assemble the data like a case control study. And then you can calculate an odds ratio. But if you want, you can also assemble it like a cohort study. And here you can calculate a prevalence ratio. So the prevalence of disease in the population is A. The prevalence of disease among the exposed group is A, and the total is A over A plus P. And then you divide by that by prevalence of disease among the unexposed people, which is C, divided by C plus D. And if you want the difference measures, your risk difference, which is based on the cumulative incidence, is IE minus I naught. And this is what we call the excess risk. This is what we call the excess risk or attributable risk. So once we subtract one incidence from the other, we subtract the incidence among the unexposed from incidence among exposed. That gives us the excess risk due to the exposure. The same way, if you want incident rate difference, here is based on person time data, same, subtract the unexposed from the exposed. So that takes us to attributable risk. How much of the disease that occurs can be attributable to the exposure? So here is public health impact. So if we know that when we remove the exposure, then we know that we can cut back on this number of disease. So whereas the relative risk is important for establishing etiologic relationship, attributable risk is important in clinical practice and public health because it addresses the simple question: how much of the risk of disease can we hope to prevent if we are able to eliminate the exposure from the population? So it indicates the potential for prevention if the exposure can be eliminated. So this is what I have been saying to you, proud. When we can estimate the attributable risk for exposed individuals, we can estimate attributable risk for exposed individuals as well as for the total population. And that is the population attributable risk or fraction. So this explains it nicely. So this one from Gordis explains it nicely. Everybody has a background risk. Everybody has a background risk. What we are interested in is the risk due to the exposure. And that is the attributable risk. And that is what enables us to quantify the relationship between the exposure and the outcome. So if you want to compute your attributable risk fraction, then you already know your attributable risk or your risk difference is IE minus I naught. So you just divide that by incidence in the exposed group, and that gives you your attributable fraction. You can decide to multiply it by 100% and get a percentage. So if you want your attributable fraction, all you have to do is that you have your risk difference or your rate difference, and you divide by exposure in the population, and then you can multiply by 100. If you multiply by 100, it gives you the attributable risk percent. If you leave it in a fraction, then that is the attributable fraction. You can also decide to use the risk or rate ratio, where you subtract the risk or rate ratio, one from the risk of, you subtract one from the risk ratio, and then you divide by the risk ratio. If you want population attributable fraction or percent, then you need incidence in the entire population. Incidence in the entire population minus incidence in the exposed group divided by incidence in the entire population. And often we do not know incidence in the total population. So you have to try and estimate that. And that is the equation we have down there to estimate that. So this is the end of the lecture on measures. If you have any questions, I can take it, and then we can break for like some 5 minutes. Maybe you want to have a comfort break. We can assemble in 5-10 minutes, and then I can try and do validity quickly in 30-40 minutes, and then we can finish this. So I'll take questions.
Sorry, Prof. I am a bit confused. I want to know the interpretation.
You said what, please?
But that attributable or whatever, it is the excess risk, but what the meaning of attributable fraction, like in terms of interpretation?
So, interpretation is what I posted in this slide. So simply, madam, we have found an exposure to be associated with disease. If we remove that exposure from the population, if we put in an intervention whereby nobody is smoking, how many people do we save from getting lung cancer? Is that very clear? We know smoking is linked to lung cancer. But if we succeed in getting everybody in the population to stop smoking, how many people are we going to prevent from getting lung cancer? Because I've already indicated that everybody has a background risk of lung cancer. So in a population, whether somebody smokes or not, somebody will get lung cancer. So that is the background risk, which is due to our genetic constitution. But if we succeed in removing smoke, putting in smoking cessation programs, and everybody in the population stops smoking, how many people do we save from getting lung cancer? And that is a public health impact. That is a public health impact. And that is the attributable risk percent or attributable risk fraction. So if you know your excess risk to be IE minus I naught, if you divide that by IE, that gives you your attributable fraction. But if you want it for the entire population, this is for your steady population. But if you want it for the entire general population, like the population of Lagos or Accra, then it means we need to have incidence for Accra or incidence for Lagos. Subtract IO, divide by incidence for Accra or population, and then we have the population attributable fraction. Is that okay? Have I addressed your question?
Yes, Prof. Thank you.
Okay. Any other question?
Prof, I'm seeing some questions on the chat box from
I'm not able to access the chat box unless Kelvin reads it. But if you please, you can post it, it's better, because that means I'll have to go into the chat box and it's a lot of hard work.
Yeah.
So if you have questions, you better speak up.
I've seen a question which says, sir, do we need to find risk ratio and the odds ratio in every study design?
But can we put a face to that question? Who is asking that question? Why don't we put a face to that question? so we can hear everybody's voice.
Nahel.
Agreed?
Yes, sir.
Yeah, so let's put a face to that question. Whoever posed that question, can you speak up? So you pose the question and you disappear. So please read the question again.
Okay, the question is saying, sir, do we need to find a risk ratio or odds ratio in every study design?
If you're interested in quantifying the relationship between exposure and an outcome, you need a measure of effect. That your measure of effect is determined by your study design. If you are using a case control study design, your appropriate measure of effect is an odds ratio. If you are using a cohort study design, your appropriate measure of effect is a risk ratio or a rate ratio. If you are using a cross-sectional study design, your appropriate measure of effect is a prevalence ratio or odds ratio. Is that okay?
Yeah, thank you.
Yes, I hope I have satisfied the disappearing participant.
Yeah, thank you so much.
Okay.
Prof, probably I'm a bit confused with the explanation. Because if at all we need to calculate the odds ratio in case control, then can we exactly get the attributed risk by the time when you use the case control as your study design?
You don't, for a case control study, you don't necessarily have to compute an attributable risk. So you see, we are using the term risk. Are you with me? We are using the term risk. Odds ratio, odds is not risk, which I have cautioned you earlier on.
Yeah.
So the attributable risk should only be computed in a case control study design or in a longitudinal design. So if you have an intervention study, like a randomized control trial, which is also longitudinal follow-up, you can do that. But for a case control study, you don't have to go and compute an attributable risk.
Okay, thank you, Prof.
Yeah. Any other questions?
Yes, Prof.
Yeah, go.
Yes.
Let's go ahead.
Thank you very much. Just like you described in the matched paired analysis for the case control, where you use the discordant pair in assessing the odds ratio. Now, in a study where I have 1:2 matching, 1 case to 2 controls, which analysis would be best fit?
Or is you use conditional logistic regression, and then you get a match pair odds ratio.
Okay.
Yeah.
Thank you.
Thank you, sir. Any other questions?
I have a question.
Yes, Nahal. Yeah, go ahead.
Sir, if we have a variable like if I find out either opportunistic pathogens exist or not.
You said are they what?
Okay, I will speak again. I'm asking, I have a dichotomous variable. I want to find out either opportunistic infections effect among the COVID patients or not.
Okay, so you have a dichotomous variable. You want to find out whether there are opportunistic infections among COVID patients.
Okay, so which type of statistical
you can use a
method
case control study. You can use a case control study. You separate the COVID patients into those who have opportunistic infections, those who do not have opportunistic infections. So those who have the opportunistic infections are your cases. Those who do not have the opportunistic infections are your controls. And then whatever exposure you are interested in, you assess those exposure histories among the cases and controls. Is that okay?
Yes, sir, yes. Thank you.
Okay. And if you publish that data, please acknowledge me.
Okay.
Any other questions? Okay. If there are no other questions, let's take a 10 minutes break, a 10 minutes comfort break. and then we'll come back half past. I think it's about 7 minutes. We'll come back half past, and then I'll try and wrap up in the next 30 minutes to 40 minutes. Thank you for your time. So don't go off, just stay online, and then we'll be back shortly. So what are the errors in epidemiological studies? Two types of errors. We have random error that has got to do with sampling, it's got to do with precision. And then we have systematic error, which is the little things that relates to collection of information, your analysis, where you are making some small errors. So those are it's got to do with measurements and stuff. That is the systematic error. So the systematic error, we have selection bias, we have information bias, and then we have confounding. So collectively, those three are the bias in epidemiological studies. And you have the random error that has got to do with your sampling. So if your sample size is very small, then you realize your estimate is not very precise. And how do we measure precision of the estimate, the interval estimate? You realize that you have a very humongous or large or wide confidence interval, which is all over the place. And that gives us some ideas. It tells us that your sample size is too small. And that's the reason why you are having a very large confidence intervals. So validity, which we have internal validity and external validity, is defined, especially the internal validity. The external validity has got to do with generalizability of your findings. How do we generalize that to the study population? The population, the reference population, sorry. And then the internal validity, which is defined here, is the absence of systematic error or bias. So validity is the degree to which inferences drawn from a study are valid. So you have quantified the relationship between an exposure and an outcome. That measure of effect, is it valid? This is what we want to try and assess. We can only assess that by ensuring that our study was devoid of systematic error. So internal validity is the lack of bias or systematic error. And this one depends on the methods, one, that was used to select the study participant. So if it's not proper, if it's not correct, then we are going to have selection bias is going to be inherent in the study. Collection of the relevant data, exposure data, outcome data. So if it's not proper, then we have information bias in the study. And that leads to something we call misclassification of exposures or misclassifications of outcomes. And we have two types of this misclassification, differential misclassification and non-differential misclassification. You could also have problem with the conduct of analysis. And that can also produce some systematic error. Internal validity also depends on the subject matter, knowledge of the subject matter. And as we established in the morning, that will enable you to make proper identification of the potential confounders and also their measurement, so that we don't have unmeasured confounding, we don't have residual confounding. Residual confounding where you have controlled, but we still have traits in there. That's residual confounding. Unmeasured, you haven't measured at all. You haven't measured at all. And you can also have over-adjustment, where you are controlling what more than necessary. Then external validity is about how the results of a study can be generalized to the target population, as I indicated. And that borders on the sample size, adequacy, and representativeness of the sample size. If your sample size is not representative of the target population or the reference population, then of course you cannot generalize your finding. If your sample size is too small, which is going to show in a very wide confidence interval, then of course, your resource is not valid. So the aim of epidemiological analysis is often to estimate the causal effect of an exposure on an outcome. This one, I think we learned it in the morning and then in the afternoon here. So here we try to decipher between what is a random error and systematic error. I don't really want to waste time on that, but a random, except to say that random error, here are sources of sampling error and biological variation, while systematic error is the minimal systematic error, which is occurs when there is a tendency to produce results that differ in a systematic manner from the true values. And this is where I said it's got to do with your measurement. If you have poor measurement and all those stuff, then it produces systematic error. So let's use this picture slide to just illustrate what precision and validity is. So the first one is where we have more precise and a more valid measurement. So the essence here is to hit the dot. The bullet will have to hit the dot. So if you look here, there is consistency. They are all hitting the middle circle. All those bullets are hitting the middle circle. So it's more precise and it's valid. If you move on to population B, there's more precision. There's precision. Because even though we are not hitting the middle circle, we are consistently hitting a certain spot. So here we have precise estimates, which will be shown by a narrow confidence interval, but the estimate is not valid. So what I just want to illustrate here is that you could have estimates that are very precise, highly precise, but they are not valid. Precise, but not valid. And the third population is where you see less precision, but there's some validity there. Less precision in the sense that they are hitting the center two circles. So the precision is low, but then there's consistency. There's consistency in the such that they are in and around the center two circles. So it's valid. So precision has got to do with statistical inference, whereas your validity has got to do with methodological imperfection. Methodological imperfection. Any questions up to this stage? Okay, so let's proceed. So this is a randomized control trial. You have your reference population. We have our study population. We are able to generalize the findings from the study population to the reference population. If we have a large sample size and the sample size is representative. So that is external validity, that is generalizability. Then the internal validity is achieved by we having a random allocation, randomize people to treatment and no treatment, and then ensure that the methods are sound, perfect. If we are able to achieve that, then we have internal validity. One thing I also want you to keep in mind is an alternate explanation for your findings. So the results of an epidemiological study may reflect the true effect of an exposure on development of the outcome disease. However, we should also take note or take into consideration that the findings could be due to an alternate explanation. So whatever we find in epidemiological studies could also be due to an alternate explanation. So you also need to make room for an alternate explanation for your findings. It could be due to the role of chance, random error. It could be due to bias, systematic error. So you are seeing what you are seeing because of information bias. You are seeing what you are seeing because of confounding bias, whether residual or measured. And you are seeing what you are seeing because of selection bias. Bias. Don't want to waste time on it. Systematic error in the design, conduct of analysis, and it gives us an incorrect estimate of the true effect of an exposure on risk of disease. Simply a result from systematic errors in the research methodology. The problem here is that we have limited tools to adjust for bias. We have very limited tools to adjust for bias. And that is the more reason why it's imperative that you avoid these biases at the design, at the analysis, at the collection of data. Because when the bias are already in there, you can't adjust for them. When the bias are already in there, you can't adjust to them. If you are supposed to collect data on a potential confounding variable and you forget to do that, once you have finished your study and you are analyzing somewhere in Nairobi, you know, you collected the data in Pretoria. Are you now going to travel back to Pretoria and say, I forgot to collect data on age or race, so I'm going to go and collect that data? It's too late in the day. So either you decide to find a tool that will enable you to adjust for that bias, or you forever stay with your biased estimate. So how do we prevent and control bias? By ensuring that the study design is appropriate for addressing the research questions. That is key. Ensure that you have a study design that is appropriate for addressing your research questions or testing your hypothesis. You need to set up proper data collection procedures and carefully monitor the process. That is the reason why it's imperative that you have research assistants who are well-trained, understand the research questions. You are going to apply the tools similarly. If you are doing a laboratory investigation, you have to ensure that you have tools or equipments that are, I don't know the term that you use, that are accurate, or whether they are specific and sensitive, those things. So that whatever is, if it's supposed to measure A, it measures A and not giving us B. And then you can also make errors in the analysis. So you have to use the appropriate analytical procedures. Most biases in epi studies can be broadly classified into selection and information bias. They can be broadly classified into selection and information bias. So what then is selection bias? Usually people confuse selection bias with sampling bias. You know, but they are different. So selection bias is present when individuals have different probabilities. So this is the thing. When individuals have different probabilities of being included in the study, according to relevant study characteristics, namely exposure and outcomes. I'll give you an example so that we can distinguish. You'll be able to know what is not selection bias and then what is selection bias. Forgive me for running very quick. So the other definition is that distortions that result from procedures used to select individuals into the study and from factors that influence participation. Systematic differences between the characteristics of the study population and those of other populations. Okay, so let's stay here. When your study population is not representative of the target population, that is selection bias. Because your study population, the essence of sampling is to get a subset of the population that is representative. Representative means all the distribution of characteristics in that sample should be the same. It should mimic or mirror that of the population. So if there are systematic differences between your sample and that of the study population or target population, then selection bias is inherent. It can occur at the stage of recruitment of participants. It can also occur during the process of retaining them. And that is what I indicated. And just to reiterate, that if you are doing a cohort study and you have a very high attrition rate, selection bias has been introduced. Because those that have been lost and those that have been retained might not have the same characteristics like the original study population that you selected. And that is the more reason why If we want to gauge selection bias in your study, one of the things that we appeal to is the response rate. Even if you are doing a cross-sectional study, and then you decided to interview 300 people, you end up interviewing 200 people because of rejection, non-participation. Selection bias has been introduced because that 300 was calculated. It was calculated. And then also you sample that 300 using a random sampling procedure, which enables similarity between the sample and then also the study population. So if you are getting a response rate of 60 or 70%, then selection bias in there, because what you have retained, the similarities are not different, unless you do something we call those that have been lost to follow up, or the non-participants, those that decided not to participate in the study. We have to look at their distribution. And if their distribution is similar to the reference population that we took the sample from, then we can allow that to pass. So selection bias can result from non-response, which I have just described. It can result from attrition, withdrawals from the study, and also losses to follow-up. And also when the analysis is restricted to individuals with complete follow-up data. As Esther said, that is the per protocol analysis. So if you do per protocol analysis, it introduces selection bias because you have restricted the analysis to only individuals with complete follow-up data. But if you are doing intention to treat analysis, then selection bias is not something that is in there. So this is it. You have a reference population. If you look at the big arrow, because of that big arrow, you have sampled more disease-exposed people than necessary. So that is selection bias. I want to distinguish between what is participant recruitment and what is selection bias, because often there is confusion between the two. Participant recruitment refers to selecting studies for a study. Studies that are conducted in a human population select subjects from a larger population, sample and population, with the nature of the selection potentially affecting generalizability or external validity of the study, but does not necessarily affect validity of the comparison. The validity of the comparisons within the study, that is the internal validity, and that has got to do with your measurement. In contrast, when a systematic error is made in selecting one or more of the study groups, as you see here, then of the one or more of the study groups that will be compared, then selection bias results. So that is the reason why selection bias is inherent here. Any questions so far? Any questions so far on selection bias? Okay, I take it that there are no questions. Thank you. So you have observed an association between exposure and an outcome. Is it due to chance? If it's due to chance, we leave it there. If it's not due to chance, we want to evaluate whether there's bias in there so that it will enable us to see whether your associations are valid and put us on that trajectory to determining whether the associations can be causal or non-causal. So if it's not due to chance, is it due to bias or not due to bias? If it's due to bias, then of course you and I know your association is not valid. If it's not due to bias, is it due to confounding or not due to confounding? If it's due to confounding, then there's still a problem. If it's not due to confounding, then we have a valid association. Then we can proceed from association to determine whether the association is causal or not causal. Information bias. What is information bias? So these are flaws in measuring your exposure, flaws in measuring your confounders or covariates, flaws in measuring your outcome variables that result in a different quality of information between the comparison groups. So if you have defects in measuring your exposure, you have defect in measuring your covariate, you have defect in measuring your outcomes, that will result in differences in the quality of information that you assemble in the table, in the groups. And once that happens, then information bias is deemed to be present in your study. Information bias, as I have indicated earlier, and just to emphasize, results from either imperfect definitions of your study variables or flawed data collection procedures. You have recruited research assistants. You have not trained them. They are about 5. You haven't trained them properly in the execution of the study tools. You haven't piloted your study tools. And yet you have deployed these guys on the field to collect data. What do you expect to happen? They are going to bring you flawed data. And this data, flawed data, means information bias. You are doing a cohort study. Another example, you are doing a case control study. If you are doing a case control study, you need to ensure that your participants are collecting the information among the cases and the controls in a similar fashion. If you want to achieve that, there has to be blinding. There has to be blinding. You have to blind your participant to the case control status so that they can collect the information in a similar fashion. Because the moment they know that this guy has lung cancer, he will try and collect the data to suggest that it's the smoking that has caused the lung cancer. So blinding is very important to prevent information bias or poor data collection or whatever, not information bias, but is designed to prevent interviewer bias. And once there's interviewer bias, then that leads to information bias. Whenever there is information bias, it leads to something we call misclassification of exposures or outcomes. So if the bias, the information bias relates to the exposure, we have something we call misclassification of exposure. If it relates to an outcome, we have something we call misclassification of an outcome. And we have 2 forms of the misclassification. But you can visualize or you can look at misclassification as sensitivity or specificity of a procedure to detect exposure. So take exposure to be a disease. If you want to detect exposure well, then your equipment or your tools will have to be sensitive. They will have to be specific. I don't have the time to go into diagnostic criteria, sensitivity or specificity. But that is how you need to take exposure. This reference here will be very good read. What can cause exposure measurement error? Once there are errors in the measurement of your exposures, then information bias is inherent and it produces misclassification of exposure. What can cause that? Problems in the collection of exposure data or an imperfect definition of the levels of exposure. So either you have problems in the collection of exposure data or you have an imperfect definition of the levels. You are not defining the levels of exposure well. If you want to undertake a dose response analysis, then we need levels of the exposure so that we'll be able to determine whether if exposure is increasing, the risk is also increasing. Dose response relationship is one of the criteria, important criteria for establishing whether an association is causal or non-causal. This exposure measurement error, which is as a result of problems in your collection of data, results from recall bias. Everybody knows what recall bias is. Somebody should educate us on recall bias quickly. Recall bias, what is recall bias? Recall bias.
This is bias that is introduced when you're conducting studies where participants are required to remember an event that happened earlier. So basically, retrospective designs, but the participants are required to remember the events that happened earlier in relation to the subject of interest.
Yeah, so that's recall bias. Let me illustrate with an example in nutritional epidemiology. We have a food frequency questionnaire, which we use to collect dietary data. So you are interested in dietary fiber consumption and breast cancer. So what do? And we could be using cohort studies, but let's restrict ourselves to case control study. So what are you doing? What you are doing is that you are interested in dietary fiber consumption and then breast cancer. You want to see whether those who are consuming less fiber have an increased odds of breast cancer. So what you do is you assemble breast cancer cases and non-breast cancer cases, and then you use a food frequency questionnaire, which is the frequency of consumption of foods that are rich in dietary fiber. So what you are going to ask the women is that over 5 years, 10 years, how frequently do you consume these foods? 5 years. How can somebody give you a very good recollection of foods they have been consuming over 5 years? So there will be recall bias there. And record bias means there's information bias. And once there is information bias, then there's going to be misclassification of exposures. Maybe I need to explain what misclassification means. What misclassification means is that instead of the person being in an exposed group, by virtue of defect in the data collection procedures, you have classified this person in an unexposed group. In the same vein, because of defects in your exposure collection machinery, instead of classifying somebody in an unexposed group, you have put the person in an exposed group. So this is what we call misclassification. The person is not supposed to be in this box, but you have put him in this box because of defect in your data collection tools. Then interviewer bias, I have explained. In a case control study, you need to blind the interviewers to the case control status. If you don't do that, what you are going to witness is that this man has lung cancer. I'm sure he's smoking more. So the interview will be biased. He's trying to get the guy to commit. And that produces interviewer bias, information bias, and then misclassification of exposures. Then in a cohort studies, you have changes in exposure status over time. You need to have a mechanism to assess this time varying exposures. I indicated in the morning section that if I have money, I'm smoking 5 cigarettes a day or 20 cigarettes a day. If I don't have money, I'm smoking 2 a day. How do you track this variance or variation in my exposure status? If you are not able to track this and you want to do a dose response analysis where you want to know levels of smoking or number of cigarettes, then it means you will not be able to do that properly. And that can also produce some bias and lead to misclassification within the levels of exposure. So if you are not able to do that, you realize that instead of putting the man in a group, in a box where they are smoking 25 cigarettes a day, you are putting him in a box when they are smoking 5. Let's not go into the details of recall bias. Esther has explained it nicely to us. Yes, Esther has explained it nicely. Push. Esther has explained it nicely to us. But what I just want to say is that recall bias is a concern in case control studies. It's a particular concern in case control studies and also cross-sectional studies where you want to get people to recall their past exposure histories. How do we minimize recall bias? If you want to minimize recall bias, use a control group that has a different disease, unrelated to the disease under study. Use questionnaires that are carefully constructed in order to maximize accuracy and completeness. So ask specific questions. For socially sensitive questions such as alcohol and drug use or sexual behavior, use a self-administered questionnaire instead of an interviewer so that they can be comfortable and be honest with their answers. Because maybe the person is not comfortable with somebody asking about sexual activity, drug use and stuff, so they will lie. If possible, assess past exposures from biomarkers or from pre-existing records. Then there is outcome measurement error, and this can occur during follow-up of the cohort when information on outcome is obtained by participant response as exposure is known. So if you are asking your participant to tell you whether they have the outcome or they don't have the outcome, your guess is as good as mine. So you need to be able to have a machinery or a mechanism whereby the outcomes are being measured in a facility. If you are doing a study and you are telling people to tell you about their weight, you know, without putting them on a weighing scale, then you and I know what the outcome is. So I indicated that there are two forms of misclassification. We have differential misclassification and non-differential misclassification. The differential misclassification is the worst form, and that is what we want to avoid. Non-differential, yes, is also a bias, but the good thing is that that biases the estimate towards the null, whilst the differential away from the null. And when it biases away from the null, that can create some panic because the estimate is supposed to be 1.2 and then it's been bloated by virtue of the differential misclassification to, let's say, 3. And then it's going to create panic that, hey, smoking is causing lung cancer by this magnitude. Meanwhile, that is not the situation. What is the difference? Like I indicated, you are supposed to classify this person in this box, and you have put that person in that box. Among the exposed group and the unexposed group, if that misclassification balances out, then that is non-differential misclassification. But among the exposed and unexposed group, if that misclassification is not balancing out, then that is differential misclassification, and that is the worst form of the misclassification. And as I indicated, differential misclassification biases the effect estimate away from the null hypothesis, whereas the non-differential biases the estimate towards the null hypothesis. I think I have explained this, we can skip this. So this is it. Non-differential misclassification of both exposure and diseases. Bias is always towards the null. So this slide tells us exactly what causes misclassification. Incorrect diagnosis. If you don't have proper diagnostic criteria, somebody comes to your clinic, the person doesn't have malaria, you are starting to treat malaria and documenting them as malaria patients. You don't have proper diagnostic procedure or weak diagnostic procedure, the person doesn't have HIV/AIDS. You have diagnosed the person as HIV/AIDS and you have put that person in that bracket. Subject self-reports. If you're asking people to recall, then of course, recall bias is a problem. And sometimes people are not honest with their record, with the information. They want to lie. They want it to look good. They don't want to tell you the truth. That can also cause misclassification. And then if you are teasing out secondary data and you are not recording properly, then that can also cause misclassification. So same thing you see down there. If we want to prevent misclassification, these are the things that we can do. we can use excellent measurement tools, very perfect measurement tools. We need to train interviewers and also blind interviewers in case control studies. We need to standardize and validate our study tools. If you want to use a food frequency questionnaire, for example, to do a work in Cape Coast, look for a validated tool in the Cape Coast population. Standardize the tools. We need to verify information collected from multiple sources. If you are asking people to do recall in the household about their cooking fuels, and you are asking a young lady, and the mom is in the house or the husband is in the house, why don't you approach the husband and you say, oh, your wife said you guys use charcoal or LPG to cook all the time. How true is that? And you get a different answer. If you are getting a different answer, then it means the first story is not true. So you need to go deep and get the actual information. That is the verification we're talking about. If we are interested in dietary fiber consumption or fat consumption and lung cancer, why don't we use a biomarker of exposure? We could do an assay. If it's vitamin D, we are interested. We could do a vitamin D assay. I know that is very expensive. It's laborious. You need to collect blood samples and stuff. But at least that gives us an objective measure of exposure. So what I'm trying to indicate here is that we should try and go for direct measurement instead of using proxies, surrogate, or indirect measurement. Use accurate diagnostic techniques. People come to your hospital, the clinicians on the call, get them to go and do laboratory tests. Get them to go and do laboratory tests rather than diagnosing them based on symptoms. You can always get it wrong. And if your diagnosis is part of a study, then you and I know that, of course, there's going to be misclassification of outcomes. Apply the same procedure in collecting information from different study groups. That is where training of the interviewers is also very important. Or don't develop questionnaires and use this one to collect information here, use another questionnaire to collect information here. And you can also find a way to evaluate this by trying to collect data on the sensitivity and specificity of your measurement tools. And then if you have this information there, you can correct for misclassification. And you are pushed to the wall and you can't do anything, you can do a sensitivity analysis. And that sensitivity analysis allows you to assess the robustness of your study findings. So if there are issues with misclassification, you can decide that you can do a sensitivity analysis restricting the analysis to some data that you think is high in quality. And then you can check that with the overall results so you can assess the robustness of your findings. Any question on information bias before we try and close the show with confounding? Any questions on information bias and misclassification?
I do have a question.
Sure, go ahead.
So you said that
non-differential.
Yes, is the worst type of bias that you can get, right?
Differential is the worst.
Differential is the worst. Yeah. And non-differential because it pushes the value closer to the null.
It biases the estimate to the null, yeah.
But now isn't that also problematic because then we're not able to see the actual effect and we might ignore a problem that's actually there.
That is also a problem. It is a problem, but it's not a big concern. It's not a big problem. In the sense that here we are underestimating, the bias here is underestimating the true effects of the exposure on the outcome. What is worse is the true estimate is supposed to be 1.5. The true estimate is supposed to be 1.5. And differential misclassification is pushing it to 3. That means we are going to go out there and tell policymakers that, hey, indeed, smoking is a serious form of And then there'll be people will be running helter-skelter, if that's what I want to put it. That's the analogy possibly I want to draw. But if it's 1.5, and then we have non-differential misclassification, pushing it to 1.2. Yes, I know we have underestimated, that has also underestimated the true risk, but it's not really a big deal. That's the reason why the textbooks tells us that the differential is the worst form, whereas the non-differential. But what you have to do is that whenever you are writing a scientific manuscript, you need to discuss the validity issues honestly and passionately. So if you think the misclassification you are seeing is differential, just talk about it and highlight the fact that it biases your estimate to the law. I hope I have addressed your issues.
Yes, you have. Thank you so much.
Okay. Any other question before I rush through confounding? Yeah, Adam.
Okay, thank you, Prof. So please, I want to find out the interviewer, does he or she have a role in causing record bias? Or what is the role of the interviewer in causing record bias?
I'm not sure the interviewer has any role. In fact, let me be very emphatic. The interviewer plays no role in record bias. The role an interviewer plays is in interviewer bias. Record bias is where, as Esther teaches us, you are asking people to recall their past exposures, or that is their eating habits. When I try and use a nutrition example or dietary listing, so you are asking people to recall their diet history over a 5-year period. That is difficult. If I sit here now, if you tell me that, oh, in the last 5 years, how much fatty fishes have you been eating? I cannot give you a very good recollection. So that is where the record bias emanates from. All the interviewer is doing is asking you to recall. He's not playing any role. Where the interviewer is influencing the process is when the interviewer is trying to force it. It's trying to force it. Oh, I smoke one stick of cigarette a day. Then the interviewer is like, are you sure? Are you sure? But you drink alcohol. You hang out with friends. Are you sure? Are you sure you are not smoking more than that? He's trying to force it. Meanwhile, he's forcing it because he knows this guy has lung cancer. When he goes to somebody who doesn't have a lung cancer, he's not going to force it. Whatever the person tells him is what he's going to take. So the interviewer has no role in record bias, unless there's somebody on the call who thinks differently. You can chip in. Are you okay, Adam?
Yes, but yes. So with the latter part of your statement or explanation, that the way the researcher will go about asking of the questions, initially I was thinking that will in a way also influence the kind of answers that
here you have given them a tool. You've given them a tool. If it's a food frequency questionnaire, you are asking them, how frequently do you consume? Once a day, twice a day, 3 times a day, 4 times a day, monthly, occasionally. So it's a matter of judgment. It's just sitting there like an indicator. If you ask me, how often do you consume fatty fishes in a month? I'll just, from the top of my head, I'll just put something there. And that is the more reason why a cohort study addresses all these issues. A cohort study which is very rigorous in the data collection, where you let them, for example, take food records. You know, you give them a diary, food diary, where they are writing everything. But even if you are doing a cohort study and you are still going in there once in 3 months for them to recollect, record bias might be inherent. So you have to reduce the time points so that you are going in there frequently. That way they will be able to recollect nicely. Is it okay? Are you happy,
yes,
satisfied?
Please. It's okay. We can go on.
Okay. Okay, sure. So let's do the last one, confounding. We've talked about the fact that you have a relationship between A and B, X and Y. You are seeing this relationship because of a third variable, which is linked to X and is also linked to Y. This third variable is what we call a confounder. A confounder must satisfy 3 criteria: causally associated with the outcome, causally and non-causally associated with the exposure, and must not be an intermediate variable in the causal pathway. So that causal pathway is movement, the trajectory, X to Y. And that confounder must not sit in the middle. If it sits in the middle, it's a mediator of the relationship. It should be linked here, it should be linked that way. And this is what guides you in identification of the potential confounders in the literature. So this is usually what I project in my class. A confounder here is L. The relationship is between exposure and an outcome Y. Confounder is linked to exposure. Confounder is linked to Y. What we say in epidemiology is that it's a common cause of exposure and an outcome. So if something is a common cause of an exposure and an outcome, it's a confounder. Confounder must not sit in the causal pathway. If you adjust for a variable which is a mediator sitting in the causal pathway, it produces bias. It produces bias. So here, the movement from U to Y doesn't happen unless it goes through M. Unless it goes through M. Typical example I'll give you is that socioeconomic status has been linked to so many health outcomes in the literature. But socioeconomic status cannot directly impact health outcomes. It has to go through several things. If somebody is poor, that person is delivering a low birth weight baby or preterm birth weight baby because the person is using charcoal and wood to cook. So the poverty has led to the woman using charcoal and wood to cook. And that charcoal and wood exposure is what is causing the low birth weight. Please, do you get me? Are you with me?
Yes, Prof. Yes, Prof.
Yes,
We are with you.
Okay, sure. So that M is on the causal pathway between exposure and an outcome. So if you are adjusting for mediators, be careful. Then we have a collider. If you adjust for a collider too, in the multivariable analysis, it produces something we call collider bias. Collider is a common effect. Confounder is a common cause. So look at how the arrows are. Collider is a common effect. So the arrows point from exposure to the collider L. So you also have to be very careful not to adjust for collider. So this is a typical confounder. You have coffee consumption and bladder cancer. And we identify smoking as a confounder. How is smoking a confounder? People who drink a lot of coffee smoke a lot. Yes or no? It's in the literature, isn't it? Yes or no? People who drink a lot of coffee, smoke a lot. And you see the relationship is bidirectional. And also people who smoke a lot, drink a lot of coffee. So smoking is related to coffee drinking. Smoking, there is ample evidence in the epidemiological literature on the relationship between smoking and bladder cancer. Yes or no? So therefore, smoking becomes a confounder of this relationship. So anything you find between coffee consumption and blood cancer, you should be adjusting for smoking. I've talked about mediator. I don't think we want to waste our time on that. Here is typical example for collider. If you are interested in the relationship between diet and heart failure, weight loss is a collider of the relationship. So if you are adjusting for weight in that relationship, then you are producing something we call collider bias. Let's look at it. Why is weight loss a collider? We say collider, definition of collider is that it has to be an effect of exposure and effect of the outcome. So let's look at it here. Being on diet can lead to heart failure, isn't it? If you are on a very strict diet, it can lead to heart failure, especially diet where your electrolytes are being restricted. You're not careful, you have electrolyte imbalance, and it can lead to heart failure. Being on diet and heart failure can lead to weight loss. So you realize that it's a common effect. Weight loss is an effect of diet and heart failure. And that is the reason why it's a collider. Sometimes you need substantive knowledge, subject matter knowledge to be able to make these deductions. It's not easy. Sometimes you need reviewers of your papers to point to you that, listen, this is a collider. So be careful, remove it. And then you go and read before you realize. So I can understand it's not as simple as A, B, C, D for you to determine that. So that is the challenge that we have here. Let's go on. I want to use the water pipe analogy, and I must admit that I stole this slide from some presentations. I want to use the water pipe analogy to explain confounder much better, something we call mixing of effects. So you have exposure to outcome. So this is a pipe. So the exposure and outcome share a common cause. So you have a confounder at the top there. So once this thing is going down there, then it's mixing the relationship. That top arrow is water that is going in there. That water is mixing the relationship. So it's diluting the association, isn't it? So if we want to see the true association, then we need to find a way to block the pipe. So if you block that pipe, then now there's no mixing and dilution of the association. Then we see the true effect. So once you block that pipe, you have controlled for confounder, and that is what we call adjustment of confounder. So you see, right, if the common cause is blocked, then the exposure disease association becomes very clear. Very, very clear. Let's brush this one for. It's still the same thing. Counterfactual. Counterfactual. So, you see, it could take me 30 minutes to try and explain this, but let's see whether I can use a minute. You see, in an epidemiological relationship, what we want to do is that we want to find a counterfactual unexposed cohort, which is difficult to find. So, David Hume philosopher talks about counterfactuals. So in epidemiology, what we want to do is that we want to simulate the counterfactual. You see, if you want to establish whether lung cancer is a cause, smoking is a cause for lung cancer, the best way to do it so that you take care of the genetic constitution of an individual is for that individual to serve as his own exposed and unexposed cohort, an exposed person. So at one point, the guy was smoking. But at the same time, he was also not smoking, which is not possible. So it means that individual at one point was smoking, at one point he wasn't smoking. But we are not able to do that. So that is the more reason why we are going to look for a suitable control or a suitable comparison group which simulates that counterfactual model. And that is difficult to find. But once you have that, then it means your risk ratio can be deemed to be causal. So initial conditions are identical in exposed and unexposed group because they are of the same population, the same individuals. But that is not possible. So if that is not possible, if the counterfactual is not possible, where that same individual here is a smoker and at the same time was a non-smoker, if that counterfactual is not possible, or that counterfactual is what will give us a causal estimate, then we are looking for a substitute that will simulate a counterfactual, because the counterfactual state is not observed. So we want a substitute that will simulate the counterfactual and then compare with the exposed cohort. So a substitute will usually be a population other than the target population during the etiologic period. So once we have a correct comparison, then we simulate the counterfactual, then we are closer to the true estimate. So what actually happens, the ideal is counterfactual, causal, and then the actual thing is the substitute. RR is I exposure divided by the I substitute. So this is what we are doing. We are using the substitute to substitute for the counterfactual. So confounding is present if the substitute population imperfectly represent what the target would have been like under the counterfactual conditions. So you have confounding if this one does not properly or correctly simulate the counterfactual conditions. Any questions on counterfactuals and confounding? Any questions on counterfactual and confounding? I assume you are all fine. Let's continue. Collapsibility, that is finally the way to also assess confounding. And here is what those of you who know stratified analysis, stratum specific estimates. So that's what we do here. So if we want to assess whether indeed a factor is a confounder, we stratify the main estimate according to levels of the confounder. So if we want to identify whether sex is a confounder of the relationship, we have a relationship between X and Y. And then we find the estimate to be 2.0. If we want to find out whether sex is a confounder of the relationship, we stratify this estimate for boys and for girls. What I mean here, guys, is that we compute effect estimate for only boys, and we compute effect estimate for only girls and compare. So this is the collapsibility. So another approach for understanding confounding is the collapsibility. Collapsibility is equality of the stratum-specific measures of association with crude. So equality of the stratum-specific estimate. So if the stratum-specific estimate, the effect estimate for boys and effect estimate for girls are the same, then confounding is present. Then sex is a confounder of the relationship. But if they are different, then it's what we call effect modifier. It means sex is a modifier of the relationship. So that is where you are going to see that the estimate might be higher among boys and lower among girls. So if you have any intervention, then you take that intervention to girls. So a factor is a confounding variable if the effect estimate is homogeneous across the strata defined by the confounder. It's a confounder if the estimate is homogeneous, the same for boys and the same for girls. So if this is the same, then it's a confounder. So if it's a confounder, then what we have to do is that we have to compute an adjusted, we have to estimate an adjusted, we have to produce an adjusted estimate, sorry. So we have our crude estimate, which was 2.0, which we stratified. So that 2.0 is our crude estimate. Then the stratum-specific estimates that we have, we'll use some formulas, what we call Minton-Hazel formula, to compute an adjusted estimate. And if the crude and the adjusted estimates are unequal, if they are unequal, then it means there's lack of collapsibility, and that confirms sex as a confounder. But if they are equal, then there is collapsibility. Then it means the sex is not a confounder of the relationship. Is that clear? Is it well understood, folks? We are closing in.
Yes, Prof.
Okay, thank you, Sir Slavin. We have negative and we have positive confounder. So confounder may overestimate or underestimate. So if you have a positive confounder, you realize that instead of the estimate being 1.2, the actual estimate being 1.2, Because of the presence of that positive confounder, the estimate become 1.5 or 1 or 2.0. A negative confounder dilutes or obscure or attenuates the relationship. So if the relationship is supposed to be 1.2, because of the presence of a negative confounder, you are going to see a protective relationship. You see something like 0.8. How do we control for confounders? We can do that at the design stage, and we can also do that at the analytical stage. At the design stage, you can use matching. I have talked about matching extensively, and I won't go into matching again. You can use randomization. Randomization is used in randomized control trials, where you randomly assign exposures. You randomly assign people into an intervention group and a control group. When you do that, the groups become similar. If you use randomization, the groups become similar. And once the groups become similar, what randomization does is that it helps to control for both known and unknown confounders. When you are doing matching, you are controlling for known confounders. You are matching on known variables. When you do random allocation controls for both known and unknown confounders. And indeed, randomization simulates the counterfactual model that I talked about. And that is the more reason why the randomized control trials is the gold standard of all epidemiological designs, because it simulates the counterfactual model perfectly. It helps us to adjust or control for known and unknown confounders. Then the other design stage one is restriction. You restrict to either your studies to either smokers or males. That is restriction. And then you eliminate the effect of a confounding variable. We've talked about matching. I won't go in there again. What are the analytical stage procedures? Stratified analysis. I have explained that. You stratify according to levels of the confounder, and then you compute the ratios, the effect estimate for each strata, and compare. If the estimate for boys and girls are the same, then it's a confounder. Then you proceed to use the Mintel-Hazel method to compute an adjusted estimate. If the estimate for males and females are dissimilar, they are not the same, then it's an effect modifier. That is an effect modifier of the relationship. And that helps us to put in an intervention to address the group that is high, has a higher risk of the disease. The challenge with stratified analysis is that you are hindered. So you are restricted to about 1 or 2 of those categorical confounders. You can use your multivariable analysis. You run your crude analysis, and then you can throw in your confounders. There are several processes. They say some backward, stepward, forward, whatever. You can read on that. But it enables simultaneous control of multiple potential confounders. And in recent times, we have cohort graphs. We have marginal structural models, and then we also have propensity score analysis. That is beyond the scope of an introductory class. Then I just want to expose you to what, again, something that is now dominating the literature, Mendelian randomization. So on my left is what is a Mendelian randomization. And on my right is what is a randomized control trial. And it's all more or less trying to control for potential confounders. But the Mendelian one is more trying to hold tight your genetic constitution. So you have population, you have random segregation of your alleles, and then you have wild type variant. I'm not a geneticist and I don't want to be one. And that influences your disease outcomes. Whereas here, randomization, random allocation to groups, control group, treatment groups, and then you are looking for disease outcomes among these ones, and then you test statistically. This chart here is a guide on how to do the stratified analysis. So you have your crude, you stratify, and the stratum specific estimate similar. If they are similar, no effect modification, there's confounding. Then you proceed, you compute your maintained Hazel. If they are different, it's effect modification. Then we put in an intervention. This is where we bring curtains on the second model. Any questions generally?
Prof,
Yes, sir.
just have a question that relates to what we have discussed today and how you can then apply this in terms of data science. Where I'm coming from is mostly you'll find out that we may need to use secondary data or data that has been collected somewhere in a large volumes to train a model. How do you factor some of these issues that we have touched on, especially to do with the biases and among other aspects that we've touched on, especially considering that you may not necessarily be carrying out the field data collection yourself?
One second. I had to make some quick phone call. You are collecting big data to train a model. You know, I think with big data to train a model, develop prediction equations, more here, you should be interested in the quality of the data. How to address missing information. And I think it's at the heart of the first session, the very first session, on how we can leverage EPI techniques to enhance data science approaches. So the way I see the application here is that what the EPI, the epidemiological concept and principles will help you to do is it will help you to identify the candidate predictors and collect data on the candidate predictors. But you know, in AI, we are not computing odds ratios, we are not computing any risk ratios. Rather, we want to generate some prediction equations. I don't know whether I have addressed your question or maybe I didn't get your question. Listen, you can come again.
No, I think you did touch on some of the aspects, though I'm looking at the various biases that we have looked at here. Of course, you address them in data quality, but you have limited control in terms of that, because if it is data that is already collected in some way, if it was collected in a manner that will cause a lot of bias, then we already have a problem that has been introduced in our model. So I in as much as I think what we have looked at today is very important. I'm still trying to say, if I go to a certain data bank that already has information, and how am I so sure that I'm going to abide by some of the issues that we've dealt with?
That is very key. I mean, yes, we are using secondary data. How do we know that the data collected is sound and is of good quality? And you and I know garbage in, garbage out, you know? So you need to, and that is the more reason why those who are collecting these, creating data sets, that is the right language, creating data sets so that people can access them from data repositories and use them. They need to annotate the data, you know.
Okay, all right.
Yeah, they need to annotate the data. They need to label the data. So we need to have some appreciation of the quality of the data. And
the metadata.
Yes, the metadata. Yes, the metadata. That's the right word. Yeah. And then also, if they are missing information, how have they handled the missing information? Have they imputed or have they left it hanging, you know? So that way you have an assurance that the data is of good quality. But indeed, you don't control that process. It's somebody's data you are going to pick. What we are doing here more or less relates to you doing a primary study, everything we have talked about here is about designing a primary study, is about collecting your data and ensuring that you have some methodological perfection. You know, your methods are sound, they are error-proofed and all those stuff. So that is what we are doing here. But indeed, but indeed, the discipline shares boundaries with data science in the sense that now there is more emphasis on big data. And where are we going to get that big data from? Those big data are data that are routinely being collected, population-based surveys. Like in the US, they have the nannies, you know, which collects biomarkers and all those things. In the DHS surveys in developing low and middle income countries, which we have used a lot to generate a lot of hypotheses. So how are they error-proof? You know, so these are things that the metadata should be able to tell us so that we can have trust in that data.
No, I think, thank you so much. I think it touches on an aspect that I was grappling with.
My pleasure, my pleasure. Any other questions? If there are not, then we'll close the show, but I think I'll allow Esther, Easter, if you are still around, to have the final word. You can possibly sum up. Yeah, you can sum up what has gone on over the past 4.5 hours to 5 hours.
Sorry, say that again.
Yeah, I said I want you to have the final word. I mean, and that final word could be whatever you want to say. Your experiences, what you think I did right, I didn't do well. Just a final thought, your final thoughts, and then we can.
Okay, thank you, Prof. I appreciate, on behalf of the team, I want to appreciate you for the great session. I think for me, this was like a refresher because my background is in epidemiology, so I really enjoyed the session. All the sessions, morning and afternoon sessions, I think have been really clear, though a bit compressed. I am hoping. Compressed. Yes, kind of compressed. So I'm really hoping, like, in our own groups, even in the WhatsApp group, we'll have to, for those who have the knowledge and at least some more material, we'll be able to share and continue with this learning session. But I think this has been a very informative session for me and I think the entire team. And we look forward to learning more. Thank you.
Okay. Thank you very much. I'm also very excited, and I hope I've been a good resource, and it's a pleasure getting to meet you guys again. And let's sustain the momentum, and we are hoping that all the instructors that have signed on to this course will be able to come in at the time that we have allotted to them, and also to deliver to your satisfaction. So enjoy the rest of the day, whether morning, evening, night, wherever you are. And then hopefully on Monday, you will catch up with the biostatistics team. I think their time has changed. Kelvin will share their timetable. They are not available in the morning. I mean, AM, when I say morning, AM, 9 AM here. I think they want to teach sometime around 2 p.m. GMT. So we'll share the timetable. I hope you are able to make time to join in. If you are not, we are also recording all the sections and then we'll put them on our YouTube channel. But as I indicated, to confer a certificate, you have to participate in all the models, unfortunately. So I wish you the best, and we'll catch up again. Thank you. Bye.